Good evening to all. Good evening to all. We would like to welcome you to the third day of the Medical Disorders and Pregnancy Certificate course being done by FOGSI ICOG. The topic for today will be infections, liver disorders, and medico-legal aspects. The convener is Dr. Sneha Buer. The coordinator for today is Dr. Raki Singh. And Raki does not need introductions because she's quite well known for her hard work throughout her tenure as chairperson. Even before that, tech support, please mute the others who are not panelists or speakers, please. And Dr. Raki is the chairperson of the Endocrinology Committee of FOGSI. She's a vice chairperson of the UP State ISAR group, and she's a peer reviewer for Jogi Journal. She has won several awards and achievements of many. May I request Raki to take over the program, please?
Thank you, Dr. Chamila. At the outset, I would like to welcome one and all delegates and the esteemed faculty for the ICOG certification course of day 3, that is today. And for this, I would like the pre-test answers to be uploaded right now so that yesterday's post-test answers we can tell it. First post-test yesterday evening's post-test answers we'll just share and move ahead. After that, the pre-test would be done of this today's ICOG. Nilima, can you share the yesterday's post-test answers?
Yes, ma'am.
Yeah. For yesterday's post-test answers were like which is the most common heart disease in pregnancy, that is rheumatic heart disease. Which heart disease is absolutely contraindication for the pregnancy, that is Alzheimer's disease. And then which of the following are the risk factors for the heart disease in pregnancy, which is the all of the above, the hypertension, obesity, and age above 40 years. And preferred route for the delivery for a patient with heart disease would be vaginal. And which of the following is not an indication for cesarean section in a patient with heart disease? Female not on warfarin therapy. Which of the following is not the risk factor for intrapartum heart failure, that is age above 40 years? Peripartum cardiomyopathy is defined as a cardiac failure after 35 weeks of gestation and up to 5 months postpartum. Which of the following parameter decreases in normal pregnancy, that is blood pressure? What is a change of position of the heart abnormal pregnancy? I think it should be abnormal pregnancy, that is upward and outward. And pregnancy is contraindicated in which NYHA class of heart disease? Both of the above, that is NYHA class 3 and class 4. Which of the following drug is contraindicated in a patient with heart disease of pregnancy, that is misoprostol is contraindicated? A 24-year-old lady with rheumatic heart disease gets pregnant. At what point of time will you be least concerned about her developing heart disease of pregnancy? It would be 24 weeks of gestation. A second gravida, para 1 patient with mitral valve prolapse goes into labor. Which of the following should be avoided? That is Tendelberg's position during the first stage of labor. You are performing a CPR on a woman who is 38 weeks pregnant. She was admitted to an emergency after a massive pulmonary embolism led to cardiopulmonary arrest. Despite the initial management of airway, oxygenation, and vasopressors support, there is no improvement. What is the cutoff time for the perimortem cesarean delivery in this patient, which is 5 minutes? A pregnant woman with heart disease is on warfarin therapy. When will the final switch to heparin be advised? At 36 weeks. What is the most common cause of anemia during pregnancy? That is physiological. What is the average maternal requirement for the iron during the singleton pregnancy, which is 1000 micrograms? And What is the minimum duration for which the pregnant woman is prescribed iron supplementation? The minimum duration is 180 days. The most common physiological cause of anemia during pregnancy is iron deficiency anemia. Decrease in hemoglobin concentration in pregnancy is maximum during the second trimester. What is the effect of anemia during pregnancy on the fetus, which is both B and C, that is macrosomia and the prematurity? Most sensitive RBC index for the iron deficiency anemia in pregnancy is MCHC. That is the most sensitive indicator. Which parameter helps to differentiate between the iron deficiency anemia and the anemia of chronic diseases, that is hepcidin? In oral iron therapy, how many iron folic acid tablets are given per day? That is 2. The most common cause of adequate response to oral iron therapy is non-compliance. What is the formula to calculate perinatal iron dose in milligrams? That is 2.4 in D, which is 2.4 into pre-pregnancy weight into hemoglobin deficit plus 500 milligram. Hemoglobin cutoff level for blood transfusion at any gestational age is 5 gram%. Which of the following is a contraindication for parenteral iron therapy? That is all of the above: hemochromatosis, first trimester, thalassemia major, all 3 of them. Clinical manifestation for anemia in pregnancies are all except infertility. A 30-year-old primigravida at 10 weeks of pregnancy presents for routine antenatal examination. Her cardiovascular examination is normal on a CBC. Her hemoglobin is 6.4 on PSB. Microcytic hypochromic anemia is seen. Nestoff test is negative. Best line for the management is oral iron therapy. These were the answers for the yesterday's post-test. And I think Dr. Parag is there, who's the vice chairperson for the ICOG. And I would like Dr. Parag to give the welcome address and the... Sir, you need to unmute yourself, sir, Parag, sir.
I think tech support has to allow him to unmute himself.
Tech support, please unmute Dr. Parag, please. Dr. Parag Biniwale, sir. Kindly do it, please.
मैम सर आप अनम्यूट करिए, आपको फोन किया है.
Sir, you need to unmute yourself now. They've allowed you, I believe.
It's okay, Raki. I think he will join.
I think in the meantime, we can do the pre-test till the time this thing is getting sorted out.
Nilima, please put the pre-test link.
Yes,
you'll be given 10 minutes, and please observe silence during that time so that the participants get time to and space to answer the pre-test. And the timer will be there for 10 minutes.
And in the meantime, tech support, kindly unmute Dr. Parag, sir.
No, I think he is finding it difficult, Raki, because they have done it.
Okay.
Nilima, the link is on.
Yes, ma'am. Yeah.
Just
Please.
not yet.
Link is not shared yet.
मिताली लिंक शेयर किया आपने?
Sir, in the meantime, you can give the address.
Yeah, thank you, Raki. Good evening, all. On behalf of the Indian College of OBGYN of FOGSI, I welcome all of you for the third day of ICOG certification course on medical disorders in pregnancy. We've had 2 exciting days where we've covered hypertensive disorders in pregnancy and just diabetes or hyperglycemia in pregnancy on day 1. Yesterday, we had a lot of discussion on anemia, and Rakhi had just given you the answers for all the questions, along with heart disease in pregnancy and thyroid dysfunction. So today is the last day and we are looking forward to a great learning session. I can see all my faculty who are, I can see Dr. Manju Puri, I can see Dr. Upma, Dr. Vaishali Korde, and so many senior faculty who are going to teach us various aspects of medical disorders in pregnancy. So once again, on behalf of ICOG, I welcome you all. Happy learning to everybody, and I'll catch up with you soon. Thank you.
Thank you, Dr. Parag sir, for the words of wisdom. I think let's move ahead. The pre-test link has been shared. Can we have the timer? Yeah. It's all for you all. Timer, please.
Mitali?
Once more, you can share the link, Mitali. People are requesting for that.
Good evening, dear all. The timing for submission of the post test is there. The time is over. Moving on ahead with our program of day 3. We've got an interesting program for us, which has been charted. The session 1 has infections and liver disorders. And the speakers for the level for the session 1 is Professor Manju Puri, Dr. Upma Saxena, Dr. Jyotsna Suri, Dr. Jayam Kannan, and Dr. Alpesh Gandhi, all the stars of teacher of teachers with us. And the first talk is by Dr. Manju Puri, and the talk is on febrile illness during pregnancy. Dr. Manju Puri is a professor and head of the department at Lady Hardinge Medical College and a subject expert for the Committee for the Central Drug Standard Control Organization and a principal investigator for NITI Aayog-led Healthcare Artificial Intelligence Catalyst Program. Over to you, Dr. Manju Puri, madam, for the talk on febrile illnesses during pregnancy, which is very important for all of us.
Thanks, Raki, for the introduction. So I'll share my screen and then we start off with the topic. So at the very outset, I would thank the ICOG team for having me here. Is my screen visible, Raki?
Yes, ma'am.
All right. So I bring you greetings from Lady Hardinge Medical College, New Delhi. And the topic which has been allotted to me is febrile illness during pregnancy. So this is a very general topic. So I just talk about the approach to a woman who presents, a pregnant mother who presents with fever. So febrile illness is not uncommon in pregnancy. The consequences depend upon the extent of fever, elevation of temperature elevation, its duration, and the period of gestation at which it occurs. Mild exposures during the peri-implantation period and more severe episodes during the embryonic and fetal development can often result in resorption of the embryo, fetal death, and structural and functional defects. CNS is at maximum risk as the surviving neuroblast cannot replicate and make up for the lost neurons. So earlier in the gestation, if the mother has fever, more deleterious would be the side effects. And higher the temperature, more deleterious would be the side effects. How do we define fever? So fever is the rise in core body temperature and is usually a sign of infection. The average body temperature is 98.6 degree Fahrenheit or 37 degrees centigrade. The rectal temperature is 0.5 to 0.7 degree Fahrenheit or 0.2 to 0.3 degree centigrade more than the oral temperature. So remember, rectal temperature is more, but we more often take axillary temperature, which is 1 degree Fahrenheit or 0.5 degrees centigrade less than oral. So I think that is what we need to remember, that we need to add 1 degree Fahrenheit or 0.5 degree centigrade in case we take the temperature through the axilla. As per Mayo Clinic and Johns Hopkins, USA, the following thermometer readings generally indicate fever. So either the oral temperature is more than 100 degree Fahrenheit or the armpit temperature, axillary temperature is 99 degree Fahrenheit. I think that is what we need to remember. Now, what are the consequences of fever in pregnancy? So depending upon the trimester, the consequences are there. In the first trimester, we've said that it can lead on to fetal resorption, that is missed abortion, miscarriage, lethal malformations or fetal death. In second trimester, it can lead on to miscarriage or fetal death. In third trimester, it normally leads on to preterm birth, but it can, a very high grade fever can definitely lead on to IUD also, especially if the baby's fetus is already compromised. Neonatal and childhood problems can also result from fever in second or third trimester. So these are in the form of cerebral palsy, autism, attention deficit hyperactivity disorder, schizophrenia, and mental retardation. So when we look at the defects, fetal defects, which are usually associated with fever, cleft lip and palate, microophthalmos, abdominal wall defects, cataract, cardiovascular malformations like atrial septal defect, hypoplastic left ventricle, etc., all are common. I have already said that CNS is at maximum risk as lost neurons cannot be replaced, and that is why these neonatal and childhood problems result. Now, what are the causes of fever in pregnancy? So if a patient mother comes to us with fever, what all things should we keep in mind? So the causes can be pregnancy related and they can be incidental. So pregnancy related causes can be septic abortion, sepsis after antenatal procedures such as CVS, cervical cerclage and amniocentesis. It could be premature rupture of membranes with chorioamnitis, or it could be group A streptococcal infections. Now that is why when we take history, so we need to rule out all these, any kind of intervention has to be very categorically ruled out. The incidental causes can be respiratory tract infection. COVID was very common in the previous 2-3 years. Swine flu. So any kind of flus have to be kept in mind. Pneumonias and tuberculosis. It could be urinary tract infection, cystitis and pyelonephritis. It could be gastroenteritis. It could be CNS infection in the form of encephalitis or meningitis. Viral infections like rubella, CMV, varicella, herpes simplex, parvovirus, and HIV. In these, like rubella and CMV, the mother may not have overtly, mother may not be very sick, but I think we need to keep, whenever there's fever with rashes, we have to keep all these things. The baby may be more affected. And then parasitic infections like malaria, dengue, chikungunya, chlamydia, trachomatis, etc. And then certain other causes which also have to be kept, as surgical conditions such as appendicitis, pancreatitis, cholecystitis, or tubo-ovarian abscess. So these are the things which have to be kept in mind. And that is why a detailed history is important. We also need to keep in mind the red flags for maternal sepsis. So there are subtle things which have to be kept in mind, which are indicative of sepsis. So fever with rigors and chills, rash, pain over abdomen, lower abdomen, purulent discharge per vaginum, excessive bleeding per vaginum. This is usually after delivery. Then nausea, vomiting, diarrhea, decreased output. If the patient is generally not feeling well, she's disoriented. In signs, things like tachycardia, low BP, tachypnea, I'm saying this is a very serious sign, hypothermia, SpO2 is low, conjunctival suffusion, abdominal signs regarding like guarding rigidity and tenderness, uterine tenderness, purulent discharge on per-speculum examination. So these are red flags. So we really need to monitor these mothers very carefully, and we have to be very aggressive as far as management of these mothers is concerned. So looking at the algorithm for clinical approach to fever in pregnancy, so it has to be a detailed history wherein we try and find out the cause for fever. And so it would include the onset and duration of fever, its severity, its pattern, whether it's continuous or intermittent, any diurnal variation, whether it is associated with chills and rigors, any localizing features. Does the woman has any cough? Does she have any urinary symptoms? Does she have any GI problems? All these things have to be, we have to try and localize as to what is the cause. And then any history of any systemic illness, say, is she HIV positive, in which case there would be immune suppression and the presentation may be a little different. Then general physical examination, we look at the vitals, we look at her level of consciousness, her hydration status, neck rigidity. And then of course, all the sites, supposing she's getting any injections, then the injection sites have to be seen, any thrombophlebitis has to be seen. So all these things have to be seen, especially if the patient is on subcutaneous or she's getting intramuscular injections, we must see those sites. Then in systemic examination, again, we do a detailed systemic examination, again, try to look for, auscultate the chest, the CVS, do a CNS examination, and then of course, a detailed obstetric examination to find out if there is, how much is the liquor, is there any sign of chorioamnionitis, sometimes they might leak without knowing. So I think we need to look at that. And of course, a per-speculum examination to look for any purulent discharge. So this is a total approach. And after history and examination, we can then tailor the investigations. So they are based on history and examination. So CBC with peripheral sphere, we would do for all our patients. And of course, a urine examination, that is what we do as a routine for all our patients. But depending on how sick your patient is, then, and do you have anything which is, indicative of a particular organ system being involved, you can have specific symptoms. In our sick patients, or where we are suspecting sepsis, so I think we must do a total panel. That is, we must do a CBC with peripheral smear, liver function test, renal function test, electrolytes, serum lactate, arterial blood gas analysis. And then, of course, in the peripheral smear, it will tell us, even if it is she's got malaria, then we do a dengue serology, Vidal test, and blood cultures. So this is a total, profile for a patient who comes to us with high-grade fever. Then we can have specific tests based on whatever the history is suggestive of. It could be urine microscopy and culture. And then swabs, depending upon whether she's got any throat infection, does she have any, vaginal infection. So we can always kind of take the swabs accordingly. X-ray can be done absolutely safely during pregnancy with abdominal shielding. In case we are suspecting any chest infection, so we can always do it. And ultrasound is a very benign kind of an investigation which can help us pick a lot of infections like liver abscess. It can help us pick, say any collection in the abdominal cavity. For appendicitis also, we can look up. For tuberculosis, we can look for mesenteric lymph nodes. So it is a very good tool for if in case the patient has any abdominal signs or symptoms. It is very important that we follow our patients, or whenever we are suspecting sepsis, or when a patient comes with fever, that we should carefully monitor her, because sometimes when they come, they are not so sick, but then they gradually deteriorate. And sometimes when they deteriorate, the team is unable to pick up. So that is why it should be, the monitoring should be more objective, and we have these modified early obstetric monitoring score systems, MEOs. So here, it takes into account the breathing, the respiratory rate, the heart rate, the blood pressure, and the temperature. and also the level of consciousness and oxygen saturation and other things. So here you see that it is color coded. So if you have the measurements falling in the red category, then it means we need to act, step up the evaluation and management of the patient. And in case there are 2 amber figures, then also it means that we need to step up the management and the we need to take look at the patient more carefully and alter the treatment. Otherwise, the patient can deteriorate very fast. So basically, we need to carry out these observations. These can be carried out by the nursing staff and by the resident doctors, by all. So everyone would be on the same page. So every time they will see the patient, they will mark all these and they will score and then follow an appropriate pathway, which can be green pathway, yellow pathway, amber pathway, or a red pathway. Now, this is a scoring system which can be used bedside. So we have it is known as quick SOFA, but there is an obstetrically modified quick SOFA as well, wherein we take into account 3 things. It is altered mental status, the respiratory rate, and the blood pressure. So if the mental state is altered, if GCS is less than 15, if the breathing respiratory rate is fast, it is more than or equal to 25. If it is patient has got hypotension. So each of this is given a score of 1. Okay, so now if the total score is 0 or 1, then it is low risk. That means we can continue the same management. If the score is 2 or 3, then it means there is a high risk for a poor outcome. And that means we need to send a septic profile of this patient and we need to look for any organ dysfunction. So, but the Surviving Sepsis Guidelines 2021 strongly recommends use of tools like Muse, News instead of quick SOFA. They feel that that is more authentic. So in that case, they would take into account the 5 or 6 things. So basically, it would be heart rate, it would be respiratory rate, it would be their orientation status, and the blood pressure. So these are the things which are taken into account, and a scoring system is devised accordingly. Now, as far as the management is concerned, we are going to have all the conditions discussed separately, but we need to treat fever. We need to keep the fever below 100 because higher grade of fever is more harmful. And we need to give antipyretics, which are pretty safe, and also add on hydrotherapy whenever required. We need to treat the cause. And if sepsis is suspected, then we should initiate the sepsis bundle. Antepartum fetal surveillance is very important. We need to maintain hydration and nutrition of the patient. And of course, initiate and score her for the need for thromboprophylaxis if indicated. Because it is important when a patient is hospitalized that we consider her, do a risk scoring as per our COG guidelines and put her on thromboprophylaxis till she recovers. The management of sepsis, there is R1 bundle. So we have to obtain all the blood and other relevant cultures, need to send the blood for serum lactate, administer broad spectrum antibiotics, and do fluid resuscitation with 30 ml of crystalloids in case the patient has got hypotension, or if she's got a lactate of 4 millimole per liter, and this 30 ml per kg should be finished within 3 hours. And we need to start vasopressors in case the mean arterial pressure is less than 65 millimeter of mercury. Yeah, so that is what is advocated. So this is a fast M maternal sepsis bundle for low resource countries. So F is for fluids, A is for antibiotics, S is for source, T is for transport, and M is for monitoring. So basically it takes up into account all the components which we have talked about, and re-emphasizes the importance of each of these components. I can't finish my talk without talking about antimicrobial resistance and rational use of antibiotics. We know that antimicrobial resistance is resistance of a microorganism to an antimicrobial agent that was originally effective for the treatment of infections caused by that microorganism. And it is a global problem. So for those who have experienced the anxiety of an infection that is drug resistant, firsthand, there is little that is needed to prove the existence and the importance of tackling AMR. But sadly, most of us are not aware of it. We must remember that if we do not tackle AMR now, by 2050, one person could die every the 3 seconds of antimicrobial resistance. Will be in the dark age of a dark age when there were no antibiotics. So we need to use antibiotics responsibly. So not all fevers you need to give antibiotics. I don't say that if you're suspecting sepsis, you should not give antibiotics. There, it has to be aggressive. But even if you have started and once you have ruled out infection, then stop the antibiotics. It is not that you've started the antibiotics, you need to give it for 5 to 7 days. That concept is no longer there. You can stop it the next day. You can stop it after 2 days. The moment you get the cultures, you can step it down also. It is not that you've started higher antibiotics, you cannot bring it down. So I think that is what is very, very important. So febrile illness is not uncommon in pregnancy. The maternal and fetal adverse consequences depend upon the degree of fever, its duration, and the gestational age. A thorough history and detailed general physical, systemic, and obstetric examination is essential to make a working diagnosis. Investigations can be tailored according to the differential diagnosis. Admission and careful objective monitoring is essential for early diagnosis of sepsis, any complications which are emerging, and need to scale up treatment. Starting all pregnant mothers with fever empirically on higher antibiotics unless sepsis is suspected is not justified and may be harmful. So antibiotics must be used rationally and stopped if sepsis is ruled out. Keep the temperature below 100 degrees Fahrenheit with paracetamol and cold sponging. Thank you so much for patient hearing.
Thank you, Dr. Manju, madam, for an elusive talk on febrile illnesses, which is one of the very important topic for us to be covered as a gynecologist. Moving on ahead, we've got a second topic on acquired respiratory distress syndrome. And we've got none other than Dr. Upma Saxena. She is a professor and consultant head at Safdarjung Hospital, New Delhi, having an experience of more than 28 years, many publications and scientific papers to her credit, and in the journals, more than 200 citations. Over to you, Dr. Upma.
Can you see my slide, Dr.?
Yes, madam. Yes, madam. We can hear you and we can see the slide.
At the outset, I want to thank the organizer for making me part of this academic So I'll be talking about acute respiratory distress syndrome today. To understand this complex disorder, it is very important to know the changes in pulmonary function during pregnancy. During pregnancy, the diaphragm, it rises by 4 centimeters, and to compensate for that, the subcostal angle increases, and there is increase in the AP, transverse, and the circumference of the chest wall. So all this leads to no change in the vital capacity, and the total lung capacity either remains same or it just decreases by 5%. However, there is decrease in the functional residual capacity by almost 20% during the second half of the pregnancy. And this occurs because of the decrease in the residual volume and also the expiratory reserve volume. And there's a compensatory increase in the inspiratory capacity. Respiratory rate remains same, the tidal volume increased by 45%. Minute ventilation and the alveolar ventilation, it increases. This increase occurs because of the increased respiratory drive due to the high serum progesterone, which acts centrally and raises the sensitivity of the chemoreflex response to carbon dioxide. So this physiological hyperventilation results in respiratory alkalosis with compensatory renal excretion of the bicarbonates. So bicarbonates is decreased to around 20 millimole during pregnancy with the arterial average of 7.44 and PaCO2 of 30 millimeter mercury. And the oxygen consumption also increased by 20 to 33% during pregnancy because of the fetal demand, and this further is exaggerated during labor. So the tidal volume increases by 45% and the total lung capacity, it remains normal or decreases by 5%. There is also increase in the basal metabolism, oxygen uptake, and minute ventilation during pregnancy. So this hyperventilated drive, it protects the fetus against acidosis, increase PaO2, and drive left shift of the hemoglobin F, leading to a healthy baby. So clinical implication of all these changes is there is increase in PaO2 to 100 to 110 and decrease in PaCO2 to around 30 millimeter of mercury. So around 75% of the women, they suffer from physiological dyspnea, and this could be distinguished from pathological dyspnea when it is accompanied by cough, wheezing, chest pain, respiratory rate more than 20, changes in arterial PaCO2, hypoxemia, abnormal echo. So what is ARDS? ARDS is a heterogeneous disorder characterized by disruption of alveolar epithelial barrier and dysregulated inflammatory lung injury. And its clinical hallmarks are hypoxemia and bilateral radiographic opacity. And the pathological hallmark is diffuse alveolar damage. It affects only 0.1 to 0.2% of the pregnancy, but it leads to maternal mortality 30 to 40% and fetal loss to up to the tune of 23%. And in a recent study, it was found that the rate of mechanical ventilation for ARDS has almost doubled. So what is the pathophysiology? So there is injury to the alveolar. There is injury to the alveolar capillary barrier. There is a decrease in surfactant, loss of aerated lung tissue. This results in protein-rich pulmonary edema, which leads to profound hypoxemia, decreased lung compliance, and increased intrapulmonary shunt and dead space. It occurs either due to direct injury to the pulmonary epithelium, leading to alveolar filling consolidation in conditions such as aspiration, pneumonia, drowning, or it can occur due to indirect insult to the pulmonary endothelium with microvascular congestion and interstitial edema in conditions such as sepsis, pancreatitis, and SIRS. So it could occur in conditions unrelated to pregnancy in which the direct causes include bacterial pneumonia, drowning, fat embolism, and indirect or extrapulmonary causes include sepsis, trauma, burns, acute pancreatitis. It can also occur in conditions which are aggravated by pregnancy, in which the direct causes include gastric acid aspiration, viral pneumonia like influenza, fungal pneumonitis, and venous air embolism. And indirect causes include pyelonephritis, malaria, dengue. And it can occur also in conditions unique or specific to pregnancy, in which the direct cause include tocolytic associated pulmonary edema, and it occurs especially when the patient is given beta agonist along with the corticosteroids for lung maturity, but it can occur in patients who are either given Maxalf and nifedipine. The other direct causes include amniotic fluid embolism and trophoblastic embolism. And the indirect cause, most important, is the preeclampsia. So majority of the ARDS during pregnancy is caused by preeclampsia, and the other causes are HELP, AFLP, and obstetric sepsis like endometritis and chorioamnitis. In non-pregnant patients, the pneumonia is the most common cause, followed by extrapulmonary sepsis, aspiration, trauma. However, in 8.3% of the cases, no specific factor can be identified. So according to Berlin's criteria, the insult should occur within 1 week of the symptoms. And on chest imaging, we should see bilateral infiltrates that cannot be fully explained by atelectasis, lung nodules, or effusion. And the cardiac failure or fluid overload should be completely excluded. We can make a diagnosis of severe ARDS if the ratio of PaO2 to FiO2 is less than 100 with a PEEP of more than 5 centimeters of water. There's a Kigali modification of Berlin definition, which was put up in 2016. And here we use SpO2, which is the commonly used measurement done in all critically ill women. So to make a diagnosis of ARDS, the ratio of SpO2 to FiO2 should be less than 315, and there's no need to measure PEEP. And the bilateral chest opacities can be seen either on chest radiograph or ultrasound. And the respiratory failure should be completely excluded, that it is not due to cardiac fluid failure or fluid overload. There are 3 stages of ARDS: acute, proliferative, and resolution state. And the women usually present with dyspnea, cyanosis due to hypoxemia, diaphoresis, tachypnea, tachycardia, chest pain, use of accessory muscles. And on examination of the chest, you will hear bilateral crackles of V's. The X-ray chest will show bilateral alveolar infiltrates without cardiomegaly. The CT will show also lung infiltrates, which is worse in the dependent lungs. So this condition has to be differentiated from valvular disease like mitral stenosis, peripartum cardiomyopathy with pulmonary edema, pulmonary vasculitis. And if the X-ray chest is normal, then the most likely cause of dyspnea is asthma, pulmonary embolism, neuromuscular disease like myasthenia. Whenever we suspect ARDS, we have to get a CBC, LFT, KFT, and we have to do ABG, chest X-ray. ECG and echo has to be done to rule out cardiac cause, and the point of care ultrasound will help us to rule out other lung pathologies like pneumonia, pneumothorax, pleural effusion, and CT chest Coagulation profile if we are suspecting amniotic fluid embolism, sputum if pneumonia, blood culture if sepsis, nasal swab for influenza, bronchoscopy in refractory case. This shows on the X-ray chest showing bilateral infiltrates, and on the right side we see CT chest showing bilateral opacities in the dependent zone. So the management needs a multidisciplinary approach involving an obstetrician, neonatologist, intensivist, pulmonary critical care clinician, radiologist, and we have to do fetal and labor monitoring, and delivery has to be planned. Cornerstone of management of ARDS are supportive care, identifying the cause, treating the cause, and formatting a plan for fetal monitoring and delivery. So we have to ensure ABC, and the positive pressure ventilation is the mainstay, and the intubation is indicated if refractory hypoxemia, labored breathing, airway obstruction, shock, and should be done by an expert clinician. In breathing, we have to maintain a SpO2 of more than 95%, and we have to maintain a mean pressure of more than 65 and urine output of 0.5 ml per kg. You have to follow a fluid restrictive strategy, and vasopressors, inotropes, and CVP, it should be depends on case-to-case basis. We have to treat the underlying cause, and if the tocolytics are culprit, then we have to stop them, and if we are suspecting sepsis, then we have to start broad spectrum antibiotics. The non-invasive ventilation has a limited role only in a hemodynamically stable patient, and we have to monitor for aspiration if we are using it. Principle of ventilation is to keep a tidal volume of less than 6 ml per kg and an inspiratory plateau pressure of less than 30 centimeters of water, and it has proven to have mortality benefits. We follow baby lung concept in ARDS. This is because of the reduced amount of aerated lung. So we have to deliver small tidal volume to prevent lung over distension and barotrauma. So we have to maintain a SpO2 of more than 95% corresponding to PaO2 of more than 70 millimeter mercury to optimize maternal oxygen delivery to the placenta. And we have to maintain a PaCO2 of around 30 millimeter mercury. Respiratory cirrhosis has to be avoided. So ARDS network trial was done, and the concept was the limitation of inspiratory lung stress reduces mortality in ARDS. So here there were two arms, one conventional arm which was given 12 ml per kg body weight tidal volume, and a study arm which was given 6 ml per kg of tidal volume. And it was found that mortality reduced from 40% in the conventional arm to 31% in which the low tidal volume was given. This was because when there is a tidal overstretch, it leads to release of systemic inflammatory mediators, especially IL-6, which leads to multiple organ failure. So if we follow a lung protective strategy, then we can avoid this damage. Ventilatory induced lung injury is the acute lung injury inflicted or aggravated by mechanical ventilation and can occur both by invasive and non-invasive ventilation. So when we give large tidal volume and high airway pressure, it worsens lung injury because with repeated opening and closing of the surfactant depleted atelectic alveoli. So in lung protective ventilation strategy, I'm just reiterating it, we have give less tidal volume of less than 6 ml per kg and inspiratory plateau pressure of less than 30 centimeter of water, and it reduces ventilatory induced lung injury, also prevents the release of pulmonary and systemic cytokines. You have to follow a restricted fluid management because it has been found that improves pulmonary edema and it optimizes cardiac output, renal and other organ perfusion. So there was fluid and catheter trial which was done in 2006 to 8, and it was found that conservative fluid strategy was beneficial with improved oxygenation and less ventilatory days. And similar approach in obstetrics should be followed to avoid fluid overload with judicious diuresis and fluid restriction, maintaining uteroplacental perfusion. So it affects the fetus also because it reduces fetal movement, it reduces fetal, it causes fetal distress, and the maternal stress may trigger preterm labor, warranting tocolysis because the hypoxia worsens during labor due to the increased oxygen demand. And fetus is exposed to various medication which mother is being given. So if the fetus is less than 24 to 26 weeks, we just have to monitor fetal Doppler. We have to just do fetal Doppler auscultation. If the fetus is more than 26 weeks, then and mother is on prolonged mechanical ventilation, then we have to do fetal heart racing once daily, umbilical artery Doppler weekly, and fetal growth every 2 weeks. There's an urgent need to deliver if the maternal condition worsens. The optimum timing and mode of delivery must be individualized based on maternal condition and obstetric indications. The decision to deliver is balancing between risk versus benefit. If the underlying cause is due to like preeclampsia, HELP, and AFLP, then we have to deliver. And there should be a joint decision with all providers. The mode of delivery is according to obstetric indications. The corticosteroid neuromuscular blockade, surfactant nitric oxide have very limited role in ARDs. However, gene therapy and mesenchymal cell therapy is promising novel therapeutic strategy based on the pathophysiological mechanism of ARDs, which I just discussed. So the prognosis improves with timely intensive care, and the main cause of death is sepsis with multi-organ failure and followed by respiratory failure. And the maternal mortality is up to the tune of 30 to 40%. The obstetric factors associated with high mortality are prolonged mechanical ventilation, renal and liver failure, amniotic fluid embolism, influenza, septic obstetric embolism, and puerperal infection. There are some non-conventional therapies also which we can use in severe ARDS. So this was an Eolia trial which was done recently in 2018, and here the extracorporeal membrane oxygenation, which is ECMO, is to rescue lung injury and severe ARDS. And it was found in this trial that ECMO overcomes severe hypoxemia and respiratory acidosis, keeping the lung completely at rest, preventing ventilator-induced lung injury. There were recently 2 systematic reviews which were done in 15-16, and it was found that they improve maternal survival, infant survival with little increase in risk of hemorrhage. It was a study done in 2022, and it was found that the most common indication for ECMO in pregnancy was ARDS, cardiac failure, and arrest. And it improves the survival of both mother and fetus. So when we ventilate in a prone supine position, then there is a overdistension of the ventral alveoli and the collapse of the dorsal alveoli. And if we do ventilation in the prone position, then there is a decrease in collapse of the dorsal alveoli and also decrease in overdistension of the ventral alveoli. And this improves oxygen up to the tune of 70 to 80%. And the proposed mechanism is that it reduces ventral pleural pressure gradient. There is a removal of effective compression by heart and mediastinum. There is increased recruitment of atelectic alveoli and increased functional residual capacity with better mobilization of secretion. So this is difficult in obstetric patient, but a left lateral decubitus position is preferred. So this was a trial done recently in 2022, and it found that it improves the prone position, it improves the prognosis in almost 60 to 70% of the patient, as their FaO2 ratio by FiO2, it became more than 1:150, which is a target for treatment. The indications for ECMO of prone position is when the patient fails to improve on appropriate ventilator strategy, or patient is waiting for ECMO, or there is, which has been found that early initiation of prone ventilation is more effective in improving the outcome. Another thing which is used is high frequency oscillatory ventilation, where this is also based on the same principle. Here we deliver extremely small tidal volume at a high respiratory frequency. And two studies have recently found that it doesn't improve. It increases the maternal mortality, is not very helpful. So to conclude, ARDS is a rare deadly disorder with high maternal mortality. It occurs due to various direct and indirect insults. The positive pressure ventilation is the mainstay of the supportive therapy. Lung protective ventilatory strategies using low tidal volume reduces ventilator-induced lung injury and maternal mortality. Fluid restriction strategy should be followed in ARDS. Time and mode of delivery should be individualized based on the cause and the obstetric condition. The non-conventional therapy like ECMO and prone positioning can be tried in severe ARDS. One of the miracles of life is that things can turn out to be so much better than we have ever imagined, and ARDS is one of them. Thank you for the patient list.
Thank you, Dr. Upma, for the lucid talk on acute respiratory distress syndrome and making us well aware about the requirement of the fluid intake and the necessity of giving importance to the respiratory distress so that the patient doesn't lands up in problem of septic shock. Moving on ahead, we've got the next talk by Dr. Jyotsna Suri. And Dr. Jyotsna Suri madam is going to talk on hepatitis during pregnancy. She is a professor and unit head at critical care obstetrics Vardhaman Medical College, Safdarjung Hospital, Delhi, and vice president of AOGD, which is Delhi, 21-22. And over to you, Dr. Jyotsna madam, for hepatitis during pregnancy.
Yeah, good evening, Dr. Rakhi. Can you hear me?
Yeah, ma'am.
Yes, we can hear you.
Can see your slides, but it has to be put up on the...
Now is it full screen?
Yeah, ma'am.
Okay, thank you.
All
So
good.
I'll start my talk. So thank you to the organizers for giving me this opportunity to speak this evening about this very important topic, that is hepatitis in pregnancy. So yeah, so this topic has got many components. Yeah, is the slide moving?
Yes, madam.
Okay, thank you. Yeah, so the incidence of jaundice in pregnancy is about 0.4 to 0.9 per 1,000 deliveries. And the challenge for the obstetrician is that the liver is difficult to palpate in the late gestation. And many times, the findings of the liver are not picked up early because of that reason. And plus, there are concerns in this case for both the mother and the fetus. And for the mother, it is that these particular, some of the hepatitis, especially hepatitis E virus and the herpes simplex virus, they can have high mortality. And then for the fetus, there is an issue of perinatal transmission as well as poor fetal outcome. So I would say that hepatic diseases, the jaundice in pregnancy, so I'm not going to talk widely about jaundice. My topic is hepatitis. But this poses a challenge for the obstetrician, especially the differential diagnosis when we do not have the reports of the patient. So, this simple flow chart which I made, for the postgraduate students, you can just see that if a patient is coming with jaundice, especially in late pregnancy, so the pruritus and other things, I'm not going to talk about, but here let's focus on the lower box. So if she comes with nausea, vomiting, and epigastric pain of acute onset, then see if she is having history of fever and see what are her AST, ALT levels. If they are more than 1,000 and bilirubin is more than 10, and especially then if you have got the time, you will quickly get the viral markers done. And obviously, if they are positive, your diagnosis is clinched. But with this background, she is more likely to be an acute hepatitis rather than any other pregnancy-induced condition. So HELP, we are all familiar that AST will be 2 times AST or ALT. Platelet will be less than 1 lakh. LDH will be more than 600. And most often it is associated with high BP. But in HELP, the bilirubin should be less than 5 to 6. And mostly the clinical icterus will not be there. AFLP is the biggest confusion for the obstetrician because it presents practically very, very similarly to infective hepatitis, which leads to acute liver failure. That is mainly the hepatitis E infection. But the AFLP, again, in 50% cases is associated with high BP. There may be little lower platelet count, between 50,000 to 1 lakh. And if you know the Swenzi's criteria, the criteria, there's 6 criteria. If they are fulfilled, then you are, more confident to make a diagnosis of AFLP. So leukocytosis, hypoglycemia, DIC, encephalopathy, enzymes will here be mostly less than 500. And bilirubin will also not be very high, and there will be a raised ammonia. So these are, there's some differential diagnosis for infective hepatitis. always the caution in red, I've written that if there is, altered sensorium or a coagulopathy with INR more than 1.5, it is compatible with a diagnosis of acute liver failure in the presence of jaundice. So if we now talk about these conditions, one by one, I'll quickly deal with them. With each case, I will, each situation of hepatitis A, B, C, we will have 1 or 2 slides. So when we talk specifically of hepatitis, we have to look at A, B, C, E, and the herpes simplex hepatitis. So coming to A is, the course is generally similar as in the non-pregnant. So we are not very worried about hepatitis A in pregnancy. It is acquired through a orophycal route. India is endemic for hepatitis A. However, there is no, per se treatment for it. It is only a supportive treatment. So the patient is asked to rest, avoid the hepatotoxic drugs, and her diet, should consist of low fatty food and high carbohydrate diet. Then the maternal and fetal complications, which you can expect in severe infection, especially in the 3rd trimester, would be preterm labor abruption, and perinatal and intrauterine transmission is a rare event with hepatitis A, even though it has been documented in some cases. So, this is about the hepatitis A. I won't talk much about it. However, now the next is the hepatitis B. Now, all of you routinely are doing the Australia antigen HBsAg in your practice for all the pregnant women who come to you. So when this chronic hepatitis B you are detecting, actually there is always an acute phase before she becomes a carrier for this disease. But this acute hepatitis B, again, like as I talked about in hepatitis A, in pregnancy, it is not something that normally presents as acute liver failure. So it is mostly of insidious onset, and it will not be very severe, and it is not associated with increased mortality or teratogenicity. Again, the treatment of acute hepatitis B is mostly supportive. However, acute hepatitis B has been associated with mother-to-child transmission in the tune of 60% if the infection occurs near delivery or if it becomes chronic. So pregnancy is generally well tolerated by women. If it has become chronic, and the HBsAg antigen persists, so these women carry the pregnancy well. However, HBsAg positive mothers should be monitored closely during pregnancy and the postpartum period, since such women are at risk of developing a hepatic flare. So because of the pregnancy, being the immune, it is an immunosuppressive condition. Sometimes the hepatic flare can take place in these women who have chronic HBsAg infection. So that is the worry for the mother. So we do periodically the liver function test, and if the ALT, so here the specific enzyme is the ALT. If the ALT increases by 2 to 3 times, you should suspect an hepatic flare, and then you should refer this case to the physician or the gastroenterologist, because she may need the antiviral therapy. Now, for the baby, chronic hepatitis is of great concern because of the perinatal transmission. So if the mother remains hepatitis B surface antigen positive or has a detectable HBV DNA, the infant should receive HBIG in addition to the routine hepatitis vaccine. So the immunoglobulin will protect the baby. Antiviral therapy for mother may also be indicated to reduce the risk of transmission. I tell you in which conditions we advocate the antiviral therapy to the mother. The infection rate among infants born to HBsAg positive mothers who do not receive any form of neonatal prophylaxis is as high as 90%. However, administering the immunoglobulin and hepatitis B, the vaccine to the infants at delivery within 12 hours you have to give, it can reduce the transmission by 95%. So now you know why you are routinely, doing the HBsAg for all the pregnant women. So prevention of perinatal transmission is by the antiviral drugs to the mother. And this is given to the mother who has an HBV viral load of more than 2 into 10 to the power of 5 international units per ml, or more than 1 lakh copies per ml of the HBV DNA. So initiate the antiviral therapy at 28 weeks gestation. Tenofovir disoproxil fumarate, that is the TDF 300 milligram, is the drug of choice and is safe in pregnancy and also has a low risk of drug resistance. So patients should be monitored for a flare if antiviral therapy is discontinued after delivery. So this is the algorithm you can all see. So a pregnant woman in the first trimester, you check the HBsAg. If she is negative, you do the routine care and give her the baby the active immunization at birth. And if she is positive, check the baseline liver panel, HBV DNA, and HBeAg and anti-HBe. If the patient, liver panel is normal, you are okay with it, HBV DNA at this time, even if it is high, you don't start immediately because we normally focus at the 28-week time. But if the HBeAg is positive and anti-HBe is also positive, either of them, you should refer this case to your physician colleague, because this patient may need the antiviral therapy for her own sake. So one is that you are giving the antiviral for her own sake. One is for the sake of the prevention of perinatal transmission. So when we are talking about, later in this algorithm, it is for prevention of the perinatal transmission. But here, if this is positive, you refer the patient even in the first trimester to the physician. Then repeat the HBV DNA and liver panel at 26 to 28 weeks. Now, if the hepatitis B virus DNA is more than 1 lakh copies per ml, you should offer an antiviral therapy to the mother, but here it is purely to prevent the perinatal transmission to the fetus. So after this, if you have given her the antiviral, the baby has to be given the immunoglobulin along with the hepatitis B vaccine. So, and for the other group, you will not give the antiviral to the mother if the HPV DNA copies are less than 1 lakh, but the baby will still receive the immunoglobulin along with the hepatitis B vaccine. So this algorithm, I think you should all remember, it is not difficult, but it is very important to prevent the transmission. Now coming to hepatitis C. So this again, acute infection is self-limiting. Again, hepatitis C is important if it becomes a chronic carrier state. And in fact, in the developed countries, because of the universal immunization against hepatitis B, hepatitis C has become the most important cause of chronic liver disease in children. And this is mainly due to the perinatal transmission. So incidence of transmission is 5% to the babies if it is a mono infection, and 10% if there is a co-infection with HIV. So because we don't have any drug which is safe in pregnancy, so basically if the woman is hepatitis C, in pregnancy you detected, there are some interventions which I will tell you in the next slide, but since you cannot treat her at that time, so definitely any woman who comes for preconceptional counseling, if you do the hepatitis C at that stage and treat her with the effective antiviral therapy before pregnancy, it would be much better. So screening of all women, pregnant women, is advisable to decrease the perinatal transmission by these measures, which I'll tell you. So who are the women who are, high transmission is associated with high HCV viral load? IV drug users, invasive prenatal testing if you are doing anything like that, prolonged rupture of membrane, and invasive procedures like fetal scalp monitoring. So if you know the status of the HCV, please avoid these situations in the pregnant woman so that we don't increase the risk of transmission. However, mode of delivery and breastfeeding is not associated with HCV transmission. So don't do cesarean for that indication, and breastfeeding is allowed. Now coming to the most important hepatitis in pregnancy, which can actually create havoc for our patient, is the hepatitis E. So this presents only in the acute form, and it is the genotype 1 and 2, which is seen mainly in the developing countries. 3 and 4 is seen mainly in developed countries. 1 and 2 is the one which is transmitted through the fecal-oral route, and it is the most virulent infective liver disorder in pregnancy, which leads to acute liver failure in as many as 25% of the cases. And here the differential diagnosis comes with AFLP, liver necrosis, as in the HELP syndrome, if there is a liver necrosis, which is not very common though, thankfully, and the hepatitis and this HSV hepatitis, herpes simplex virus hepatitis. The maternal mortality is up to 20% in the Western literature, but I think in India it is even more. The poor fetal outcomes which are associated with this infection are the miscarriage, preterm birth, preterm prom, IUD, and stillbirth. And the neonates can also have massive hepatic necrosis and also neonatal mortality. Vertical transmission is also associated with neonatal mortality, and transplacental transmission of HEV virus has been seen in 33% of the neonates. So the management here is strict vigilance for acute liver failure. Development of what is acute liver failure, I'll tell you in a slide, next slide. You have to give supportive care to the patient. There is very little data to support termination of pregnancy to improve maternal outcome, which is the INALS and FOGSI position statement of 2019. And the decision to terminate for fetal outcome has to be individualized. So here prevention is very, very important because there is no role of PEP or immunoglobulin. So the pregnant women should be counseled directly right from the beginning of pregnancy, especially in areas where the hepatitis E is rampant, to take care of their water and their food hygiene. So the HSV hepatitis, this is something which occurs very silently. It is one important cause of acute fulminant hepatitis and acute liver failure, poor maternal and fetal prognosis again, and should be considered in all cases of acute liver failure in which there is anicteric hepatitis. The enzymes are high, coagulopathy is there, but the bilirubin will not be very high, and your other viral markers will all be negative. Vesicles may occasionally be seen, but not in all cases. If you see vesicles, the diagnosis becomes more certain. You can send the fluid for culture, and of course, you can also, in suspected cases, send the serology. Empiric acyclovir should be considered in such cases, and termination of pregnancy does not improve the outcomes. So what is acute liver failure? It is characterized by acute liver injury, hepatic encephalopathy, and an elevated prothrombin time or INR more than 1.5 in a patient without cirrhosis or pre-existing liver disease. Also, we call it fulminant hepatic failure, acute hepatic necrosis, fulminant hepatic necrosis. These are all terms which we use for acute liver failure. So main is that the illness duration is less than 26 weeks, and it can be divided into hyperacute and subacute stages. So most important cause in the developed countries for acute liver failure is drug-induced, whereas in the Asia and Africa, it is the viral hepatitis. So management of acute hepatic failure, maintain the fluid balance, maintain electrolytes. So hyponatremia can worsen the brain edema, and hypokalemia can increase the renal ammonia. So take care of the electrolytes very well and carefully. Maintain normoglycemia, because with acute liver failure, there is very high chance of hypoglycemia. So keep it above 65 and maintain the acid-base balance. Avoid all hepatotoxic drugs, especially acetaminophen, amoxicillin, clavulanic acid, flucloxacillin, and erythromycin, and ceftriaxone and aminoglycosides if there is a renal injury also along with that. So the hepatorenal syndrome. So these drugs are practically to be given very cautiously. Acetaminophen we don't give in our obstetric HTU ICU whenever we have patients with liver failure. Just be very careful about these drugs. Maintain the nutrition at 60 milligram protein per day by the oral or the enteral route. And if patient, because these patients very often will be very irritable if they are going into encephalopathy, so they may need sedative medications. So here the benzodiazepine, barbiturate and propofol are preferable to opioids because opioids can decrease the seizure threshold in the when they have the hepatic encephalopathy. The other things are, keep the blood pressure, mean arterial pressure at least 75 millimeter of mercury so that the cerebral perfusion pressure is, well maintained. Lactulose and rifaximin have a limited role. So these latest evidence has shown that these are not very useful in acute liver failure. Prophylactic administration of FFP is not recommended. Just because INR is deranged, don't start giving FFP unless you have to do some intervention or she is bleeding from any side. Stress ulcer prophylaxis is always indicated in such cases and prevent further increase in the intracranial pressure by decreased stimulation. Raise the head end at 45 degrees, maintain good fluid balance, prevent recurrent convulsions, and maintain sodium between 145 to 150. And of course, always do surveillance for early, treatment and surveillance for infections like respiratory infection. And these patients are also prone to bacterial peritonitis. So to summarize, acute hepatitis in pregnancy can have both poor maternal and fetal outcomes. B and C can persist as chronic hepatitis and lead to perinatal transmission. E infection in pregnancy has grave consequences, which can lead to acute fulminant hepatitis in 25% of the cases. And maternal mortality is high. Fetal outcome, including preterm, IUD, and vertical transmission of infection can take place in these cases. There is no evidence that delivery of fetus improves the maternal survival in hepatitis E infection. The treatment is mainly supportive and consists of management of acute liver failure with a multidisciplinary team. So thank you very much for the patient hearing. And I again once more thank the organizers to give me this topic. Thank you.
Thank you, Dr. Jyotsna. At the end of the day, we are more learned with the hepatitis as an infection and what we have to treat and where and how much has to be given. Moving on ahead, we've got a very important topic for us for today, which we are not that very comfortable in dealing with, which is etiopathogenesis and clinical features of septic shock. That nobody else, none other than Dr. Jayam Kannan, who is the best person to speak upon. And Dr. Jayam Kannan is the Emeritus Professor at the Tamil Nadu MGR Medical University. She is a FOGSI Adolescent Health Committee and Best Committee Awardee in 2013 to 15 and a Vice President of FOGSI in 2018. Over to you, Madam.
Thank you. Thank you very much for this wonderful opportunity to speak on etiopathogenesis and clinical features. Very specific given talk. In the febrile illness, some of the clinical features and the management has been covered by the speaker. And following me is Dr. Alpesh, who is going to speak on the management. Coming to this thing on this topic, yes, maternal sepsis is very, very important because it's the third important cause of death in a pregnancy. And we also celebrate a week-long celebration imparting the knowledge in the third week of May, 14th to 20th is that one. What all created a big havoc in the last 15 years compared to what we have been seeing before 2010 is death of Savita Halappanavar at UK, Ireland, when she had a ruptured membranes. And the hospital kept her silently in the hospital. She was going up with fever, everything. Lot of hue and cry was made by Professor Arul Kumaran. Still, quoting the law, they refused to induce termination. She was knocking at the death door. She was gravely ill and died after 8 days of stay in the hospital. That made Arul Kumaran, elect FIGO president, jump on his toes, and he brought in all the changes. Every year we have been getting new things on sepsis, septic shock, and the MEOS, everything came. And also the legal system was drastically changed in the United Kingdom, thanks to the loss of our own dear soul, a dentist. Yes, many infections resolve on their own. Why not sepsis in pregnancy? It's because the pregnant woman has already undergone the maximum physiological changes and has undergone the best immunological adaptation. What more to do if there is a virulent organism? Because in spite of all these things, what happens is, in unable to tolerate the problem, one of the organ goes in for problem, either in pregnancy, abortion, and postpartum. All these things become a threatening condition to the patient. The stages of sepsis which has been given are, depending on the immune system, the overdrive occurs. If you have driven to the maximum, you are in the septic shock. If you are little below 200 on your driving capacity, you are in severe sepsis. The septic abortion is another separate entity which has been discussed very clearly. Even last year, there has been a lot of details by this revision in October 2022. Sepsis in puerperium is also very much talked about because 1 in 8 pregnancies, death in the United States is due to puerperal sepsis. Now, coming to the etiology, which has been given my talk, as I have said very clearly, inflammation is hiked. With the inflammation hiking, coagulation abnormalities peep in. All the anti-inflammatory mechanisms have been already killed. Immune suppression is killed. All the cells, because there is no way they have been guided, they start massively, erratically growing on their own. And every cell of this is a component of the endothelial system, and the endothelial system totally comes down. And with the endothelial system coming down, then and there is blood clotting, microvascular thrombosis. What happens? The microvascular thrombosis stops the blood flow, ischemia occurs, and the patient has to end her life. These have been set as a Webster, and the set point which have been cleared in the etiology of the immunoadaptation in pregnancy has been with classical monocytes, neutrophils, regular T cells, CD4 cells, and platelets. What happens to these cells? If you look at it, on the side, left side, we have the mild suppression, increased neutrophils, increased monocytes, a drop in platelets, all in 3rd trimester of pregnancy to adapt to the fetal circulation and make it well that the baby grows. But when the sepsis comes in, all these things become heavily lost with all the classic features which are going up, with the result that the drop in the platelets has been so much that it invites all the problems up suddenly. To look at these cellular changes in the total immune system onto the sepsis, if the sepsis immunity is lost, the inflammation comes in with the type of the virulence load of the pathogens that are there, which result in complementary activation, coagulation, and apoptosis of the cells. The anti-inflammatories are asked to go back as the inflammation prompts out, and it also results in the chromosomal gene transcriptions. And automatically, the DNA methylation is also put into a disarray. Look at the cell which is there. In the cell, normally, when the glucose enters, it has to go through the Krebs cycle and it has to produce a lot of acetyl coenzyme A so that the cell can function well, the mitochondria can function well. But in a septic patient, the glucose, instead of going into acetyl coenzyme A and giving a TCA cycle properly, it goes into pyruvate lactate and goes out as lactate. Lactate is useless for the cell. it cannot be used. With the result, at the cell, the basic mechanism of oxidative phosphorylation is brought down. The fatty acid oxidation is dominant. Fatty acid oxidation is not going to support an ordinary cycle work. With all these things, apart from these changes in all these things, there is also immunopathological changes, which is called pathogen-assisted molecular patterns. This PAMPS is a one when it peeps into the cell due to the bacterial liposaccharide, flagellin, and lipoic acid, the viral DNA and RNA, which initially produce a hyperinflammation, automatically going for immune suppression. So, looking at we have looked at the basic of a man, woman, then the cell. Now look at the chromosomal level and details. The bacterium, depending on it in the cell, the chromosome undergoes various histone changes. So the genomics sets in, and the genomics problem goes in with the epigenetic problem, and the epigenetic problem alters the DNA patterns with the messenger RNA going in for disarray. The transcriptomics enter in, the proteomics are not able to function normally and produce the regular proteins which are required. Finally, everything lands looking at the lipid metabolites. Lipid fatty acid oxidation and lipid metabolism is not going to support the normal mechanism. With the result, the lungs, kidney, everything goes into failure. And if only we have to see that we are able to clear this infection properly, the innate immune response should be made into an adequate immune response by all our methods. And the PAMPs and macrophages, which are destroying the cells with a cytokine storm, should be put down so that the fever, shock, and organ failure is brought down. The antibiotics given are appropriate to decrease the phagocyte, and the immune exhaustion is brought down. The apoptosis is kept at rest, so the cells are able to function with the proper CD4 and CD8 cells. With all these things, in 2018, we came with sepsis in steps. So we had the SIRS, sepsis, severe sepsis, and septic shock. If you are seeing a patient in severe sepsis, our duty is to make it a SIR. If you are seeing it as septic shock, at least first quickly get it into SIRS and then sepsis and then go into SIRS. This is what is, instead of putting it as a forward mechanism, I will say a patient whom I have seen in a septic shock, I'll be more worried about the lactate and bringing her down to this level rather than making it a normal level. With all these years of changes, still what definition we said in 2017 remains today also a couple of months ago, and it is continued as a sepsis with an organ failure. To give the incidence, as we are talking about MMR in lakhs, I say for every lakh of deliveries, you will have 400 cases of maternal sepsis, and maybe 8 per lakh can go in for death as a cause of infection. Of this 80 deaths, if only we give a proper treatment, 65%, that is 50 to 60 cases, we could bring them back to life normally. Only 20 per lakh we should reach. Why I say normally is because unless we give a very quick recovery, these people can have a long-term complications and go in for reduced outcomes. The source of infection is known to everybody. All the sources which are on earth are available to the pregnant woman also. The bacteria which are causing mostly are the E. coli, 37%, with this Staphylococcus and Streptococcus also coming in. Few cases of this thing, Candida sap, is also found to be there. The obstetric factors, if only we are doing emergency LSCS on a PPOROM case, or we are doing any invasive procedures on these patients, on a patient who is a primary gravid with low socioeconomic status, with pre-existing medical problems, with having been using antibiotic for quite some time for other factors, we are going to face risk in sepsis. In they saying placenta preta syndrome managements also, all the surgical procedures can also invite septic shock. Group B, is it there in India? To my knowledge, I have not seen any cases group B streptococcus in my area. The risk factors also include HIV, malignancy patient who are conceived, a patient who has gone in for transplant. All patients who are obese, who have dissing, GDM also have to be considered for sepsis. The diagnosis, as it is very clear to everybody, is only on 4 important factors, that is the heart rate, blood pressure, WBC count, and lactate level, which is going to be taken first, which is we are going to wait for the follow-up is the question. So the diagnosis size from 2002 has been quickly coming down with 13, 14, 16, 17, and 18. And 16, we were following the SIRS as per CMDC. And 17, we came with the SOFA. And in 18, we have come with a quick SOFA, saying that we don't look at all the other factors, only 2 important things: respiratory rate more than 22, blood pressure less than 100 milligram, 100, they say, in a systolic, and if you are able to do a Glasgow score, look at anything above 13. All the clinical features which has been already put up by Manju is already there with all these cases, and this is a MEOS which has been given with all the green, yellow, red, orange, all the colors which are available for only in great tertiary care centers, not for the other thing. In every labor ward who is having more than 30 deliveries per month, I would request them to put this chart so that they can know how to manage a patient with sepsis. Are you going to look at the lactate level? Yes. While you are treating this patient, you are going to take the blood for lactate level, and at the same time, not to forget about malaria, dengue, and other also causes for the septic shock. The red flags, which has been already told, she put all the red flags together. For stage 1, it is 101 degrees with a respiratory rate more than 20 and heart rate of 90. For stage 2, you start getting reduced urination, platelet count starts coming out, and the skin patches start appearing. In stage 3, how long you have been in stage 2, how quickly you change to stage 3, and how long you stay in stage 3 with all the definite organ dysfunction is the one which is going to say whether it is going to kill you or not. Singer in 2016 made very clear about the serum lactate level and hospital mortality rate, which is being kept up even today. And he pointed about the pulmonary dysfunction, renal dysfunction, liver dysfunction, and metabolic derangements. Adrenal insufficiency is also being talked about, but not being investigated so much. And improving the diagnosis, we have to look at the new maternal sepsis toolkit of 2023, a 2-step approach to screening and management. And this nicely gives about all the details of the guidelines. Please note this and go into this gloss and look at all the details so that you can convert the 3 hours and 6 hours bundle to an 1 hour bundle. Quickly put all the problems into treatment, even though we may say one size never fit all. Let us err on the wrong side of overcorrection and then come down to the normal correction, depending what we have been seeing. The bundle which gives in this one, which is going to be very clearly discussed about Alpage, contains more about catecholamines, heart rate, fluid, and other things, antibiotics. The P summary which I would like to give is, none of the systems can perform well. Please take a clinical feature of mean arterial pressure of 65 as a tool to initiate your treatment. GLASS guidelines 2023 should be taken up for etiopathogenesis and clinical features, and all this bedside treatment which the Alpesh Gandhi is going to come out. Please look into it and go with your patient and see that they quickly recover with all the immune metabolic adaptation which are in our knowledge, and do little more possibly research in hospitals like Delhi institutions and also in other tertiary care institutions, so that we are able to bring next year some more details on the etiopathogenesis so that we can adapt ourselves better to the immunomechanisms. And infection control in hospitals is very, very important. If you are going to continuously get sepsis cases, that means we have to look at ourselves, clean the beds, Overworked staff, please give them proper rest, and also ask the residents to be properly aseptic also. Thank you very much for your patient hearing, and look into this toolkits for your further management. Thank you very much. I stop my sharing and over to the organizers.
Thank you, Jem ma'am, for the lucid talk. As usual, it was the best one. And
Thank you.
moving on ahead, we have got Dr. Alpesh Gandhi with us, the past president of FOGSI. And he was the governing council member and the former practical obstetric committee chair in 2009 also. And who else could have talked better? And he's well known for the management of septic shock all over India and the emergency care. Over to you, Dr. Alpesh Gandhi, sir, for the management of septic shock during pregnancy.
Thank you, Dr. Rakhi, for the kind words. Thank you, Dr. Lakshmi, Dr. Sukuma, Dr. Parag, Dr. Parul Kotadawala, Dr. Sneha Buyar, and Dr. Rakhi, all the organizers for giving me this opportunity. This is a very important topic close to my heart. Managing sepsis in obstetric HDO ICU. Dr. Jem Kannan has nicely elaborated the etiology and clinical features. So why sepsis and septic shock to be managed in obstetric HDO ICU? This is the first question comes to my mind, because puerperal sepsis accounts for 10 to 12% of all maternal deaths, and Dr. Jem has mentioned it is third or fourth main cause for maternal mortality. And when, as per the WHO, when patient develops septic shock, then the mortality is very, very high, 55 to 60%. And the important aspect is maternal deaths from sepsis are largely preventable, and they died because of delay in diagnosis or management. Another sad side of sepsis is across the globe, the incidence of sepsis is increasing over the last decade. Maybe because of the older maternal age at delivery, maybe because of the increasing incidence of gestational diabetes mellitus, or maybe because of increasing obesity, or maybe because of environmental problem, whatever the reason is, but the incidence is increasing day by day. And that is why it is very, very important for all of us to know the management thoroughly. And as mentioned, when there is infection, our body shows adequate innate immunity, and because of these signs, symptoms does not appear. But when there is inadequate response, then patient may develop signs symptoms of infection. And when there is innate immune dysregulation, organ dysfunction can happen, and this can lead to sepsis. So these are the common infection in our obstetric practice, maybe postpartum endometritis, lower urinary tract infection, septic abortion, chorioamnionitis, necrotizing fasciitis, toxic shock syndrome. These are the common reasons, common infections in obstetric which can lead to sepsis. And these are the concurrent infection, maybe pneumonia, endometritis, pyelonephritis, meningitis, tuberculosis, HIV, malaria, whatever. There can be many different concurrent infection in women with severe sepsis. But as delay is dangerous, we should always be very much suspicious and ready to tackle all these common infection in our obstetric practice. Why it is a challenge? When sepsis occurs in obstetric patient, it is always a challenging because there is overlapping between the physiological changes in vital signs and inflammatory response because of sepsis. And we all know that there are certain physiological changes occurring during pregnancy. Both these changes are overlapping. Because of these signs, symptoms happen because of sepsis are less distinctive. Particularly, we all know that high pulse rate and low blood pressure are common findings in pregnancy. Also, another important thing is when sepsis occurs in obstetric, disease progression is much more rapid, faster development of complications occurs, and both mother as well as the neonate both can be affected. And our patients are relatively younger. They look very well until they are almost serious. So because of all these reasons, it is always challenging when sepsis occurs in obstetric patient. And I have mentioned it is very, very important. Early suspicious, early diagnosis is very important. And these are the signs, symptoms already mentioned by Dr. Jayam. So when we come across any patient, obstetric patient having this type of signs, symptoms, immediately we should thought for possibility of sepsis. And these are the laboratory findings. Again, if we come across any such finding in our obstetric patient, immediately we should think that this patient may have sepsis, and we should think in that way. As discussed, life-threatening organ dysfunction caused by a dysregulated host response to infection. But the important thing is how to define organ dysfunction, and when sepsis with persistent hypotension occurs requiring vasopressor to maintain mean arterial pressure, it is known as septic shock. So how to diagnose organ dysfunction? Already just discussed very briefly. Previously, there was SOFA score where hypotension, tachypnea, and altered mental status were considered. Actually, the SOFA score was considered, but SOFA score is a little bit complicated and frequently used only in ICU. So from that, a quick SOFA score comes, and if 2 or more findings are there, then patient may have sepsis and having the greater risk of poor outcome. But as we all know that in this quick SOFA score, the level of systolic blood pressure is considered 100 and respiratory rate is considered 22 per minute. Whereas it is a common frequent observation in our obstetric practice that many pregnant women may have blood pressure without any problem of sepsis. They routinely have blood pressure between 90 to 100, and they may have more respiratory rate and pulse rate also. So that is why from this obstetric SOFA score, modified score, quick SOFA score comes out, and according to this obstetric modified quick SOFA score, now the systolic blood pressure of 90 millimeter or mercury or less than this is considered. Similarly, respiratory rate 25 or more than 25 is considered, and of course altered mental status is there. So out of these 3 findings, if patient is having 2 or more findings, then it is considered that obstetric modified quick SOFA score is positive. So immediately, if patient is having this type of quick SOFA score positive or any of these clinical signs, symptoms with laboratory findings, immediately we should manage the patient with immediately we should admit the patient in obstetric HDO ICU, and immediately we should manage with the surviving sepsis campaign with the septic bundle. And bundle means elements when used together improve outcomes more than when they used separately. It is evidence-based, it is in fixed goal, and it is also in a sequence and fixed time also. So it is very, very helpful. So immediately we should work to manage the patient with the septic bundle. It is also known as our 1 bundle, should be initiated within the first hour of the recognition or suspicious of the sepsis. And initially there is a resuscitation phase and then the management phase. And as I have mentioned, always admit such patient in obstetric HDU or ICU in the resuscitation phase. Care has been taken for the airway, breathing, circulation, disability, and for the monitoring, immediately monitoring should be started. And for that, 5 simple variables are monitored: heart rate, systolic and diastolic blood pressure, respiratory rate, temperature, and mental function are monitored. And of course, along with this, hourly urine output is also monitored. So monitoring is very, very important when we are having suspicious that patient is having sepsis. And this is the immediate management of first hour. Immediately start high flow oxygen if patient is having impaired oxygen delivery. Immediately take IV line with a wide bore needle and immediately start IV fluid resuscitation with usually with normal saline at the rate of 30 ml per at the dose of 30 ml normal saline per kilogram of body weight. immediately also before this take blood culture for the complete blood count, serum lactate level, and many other related investigations. But do not wait for the report to come. Immediately give broad spectrum IV antibiotic, empirical, and if required, we can change after the culture report. But we should not wait for the culture report to come. And of course, when there is increased serum lactate level, elevated level suggest aggressive resuscitation. And of course, accurate urinary output monitoring is important. So immediately within first hour, we should work for this. And as initial bolus of 30 ml per kilogram of balanced crystalloid is given, after initial fluid resuscitation, further fluid therapy can be guided by CBP or by dynamic measures of preload by using pulse pressure variation or passive leg rising. It is many times it is observed that about 50% of hypertensive patients with septic do not respond to fluid challenge and they require vasopressor. And if it is delayed, then patient may develop septic shock. They will not respond to this fluid challenge and may require vasopressor. So such type of patients should be immediately shifted to obstetric ICU. And this is the algorithm how it has to be managed. Immediately norepinephrine drip is to be started up to the 10 microgram per minute dose. If with this dose, when there is adequate BP and perfusion, we are done. If there is a still persistent hypotension, then add vasopressin 0.04 units per minute, and then again watch for adequate BP and perfusion. If it is okay, then we are done. If it is not there, and if persistent hypotension is there, then titration of the norepinephrine drip is done. Dose is increased to 25 microgram per minute. And again, it is watch for blood pressure and perfusion. And if it is adequate, it's okay. If it is not adequate, when there is severe tachycardia is there, if possible, if available, bedside echocardiogram should be performed. And if hyperkinetic ejection fraction is there, then continue up titrate norepinephrine. And if it is not there, epinephrine challenge test can be considered. And if it is a patient respond well to epinephrine challenge test, then up titrate epinephrine and down titrate norepinephrine. So this is the algorithm or protocol when patient of septic shock is admitted in obstetric ICU and when they require inotropic support. So in obtain blood culture prior to antibiotic administration, this already we have discussed this protocol, but when in the event of persistent hypotension despite fluid resuscitation, if possible, if it is not always required because now other methods are there, but if at many places still central venous pressure is line is taken, and try to keep CVP at the rate of 8 or more than 8 millimeter of mercury. Again, important is there are so many antibiotics are available. We should select the broad spectrum antibiotic, but again for broad spectrum antibiotic, certain antibiotics have coverage of certain microorganisms only. So which antibiotic is better? It is always confusing. But the piperacillin and tazobactam or meropenem is the ideal antibiotic or preferred antibiotic, we can say, along with gentamicin or micacin. So this is the and ciprofloxacin or ciprofloxacin and metronidazole with clarithromycin or clindamycin and gentamicin is alternative in those who are having allergy to penicillin. So in my practice, most oftenly I am using piperacillin, tazobactam, and or meropenem with gentamicin, and I have found this combination very, very useful. So this is the choice of antimicrobial. And again, about the corticosteroid role is controversial, but where hydrocortisone should be reserved only for septic patients with refractory shock, those who remain hypotensive following initial fluid resuscitation and vasopressor. patient receiving corticosteroids should be cautiously monitored for hyperglycemia and hypernatremia. And it should be when patient shows signs of clinical improvement, gradually it is also dose is decreased and then stopped. Another important benefit, of course, lung maturity, we all know that. And when patient is having sepsis, prevention of deep vein thrombosis is essential in septic managed pregnant patient, as both pregnancy and sepsis are associated with hypercoagulability. Methods management for the prophylaxis of DVT are always, we should advise them for compression stockings, intermittent lower limb compression, low molecular weight or unfractionated heparin can be given if required. And again, there is a significant role of intravenous immunoglobulin, particularly in high dose, have been used in pregnant women and is effective in exotoxic shock caused by streptococci and staphylococci, particularly when they failed because of its when other methods management failed. Already this score, these are the different score already discussed, and this is very useful score to manage the patient when patient to monitor and manage the patient. Sometimes we may need to go for the decision of delivery. Decision of delivering the fetus or continuing the pregnancy is influenced by patient's condition, gestational age, fetal status, presence of chorioamnionitis, labor, and many more other conditions. But generally, in critically ill pregnant woman, birth of the baby may be considered if it would be beneficial to mother or baby or both. At the same time, we should always remember that attempting delivery of unstable mother increases the maternal and fetal mortality rates unless the source of infection is intrauterine. So we should also try to identify the source of infection at the earliest. Another important thing is newborn complications are very common when patient is having obstetric patient is having sepsis. Maternal sepsis has a significant impact on neonatal mortality, as well as intraamniotic infection can cause neonatal sepsis, pneumonia, respiratory distress, and long-term neurological impairment in infants. So we should also be watchful for neonatal management and monitoring also. And we should also make neonatologists aware about this possibility. So try to identify the source of infection at the earliest. If required, we may have to go for surgical drainage or removal of infected tissues. Particularly, we may sometimes need uterine evacuation, abscess training. Sometimes we may have to go for hysterectomy or even cesarean section for chorioamnionitis. So whenever it is required, we are sure about the source of infection, and if required, we should go for surgical management also. But at the same time, if surgical intervention is mandatory, anesthetist has to make the decision on regional or general anesthesia. Usually, septic patient may have hypotension and may not tolerate the sympathetic block and vasodilatation associated with spinal anesthesia, and therefore the routine choice is general anesthesia. General anesthesia is highly likely to be required in a septic obstetric patient if surgery is required. Again, for the post-operative care management, such type of patients should be referred to transfer to critical care. Sometimes it is needed if the patient is hemodynamically unstable, needs vasopressor support, mechanical ventilation, or a patient is having altered conscious level, hemodialysis, multi-organ failure, or hypothermia. If patient is having any of such condition, or if patient require any such type of management like vasopressor support, then immediately this patient post-operatively should be shifted to obstetric ICU. Prevention, of course, is very, very important. Early diagnosis is important. Prevention is also very important. We should train our staff, particularly for the catheter care, skin care, position care, hygienic care, and individual level risk factor, anemia, obesity, identification of these. Health workers need to be adequately trained and skilled to be able to recognize the signs, symptoms of sepsis and to treat the condition effectively. So training, counseling, prevention, early detection, all are very, very important. So in conclusion, initial management of sepsis in pregnancy is very important. Within first hour of suspected sepsis, obtain culture, serum lactate level, administer broad spectrum antibiotic, initiate fluid therapy up to 30 ml of normal saline per kilogram of body weight. Try to maintain mean arterial pressure, minimum 60 millimeter of mercury. Ideally, it is advised for 65 millimeter of mercury, but in obstetric patient, if we can get it above 60 millimeter of mercury, it is good. Then start, if required, still patient is having septic shock and hypotension is not responding there. Then the start norepinephrine drip through central line if possible. Start, if required, low dose steroid, and achieve early source control using imaging studies if required whenever, and consider electronic fetal monitoring at 24 weeks of pregnancy if pregnant woman is having sepsis. Consider steroid if required. Early enteral feeding, initiate DVT prophylaxis, and avoid, this is again very important, avoid hyperglycemia above 180 milligram because without diabetes, this patient may develop hyperglycemia. So in conclusion, recognize septic shock early. Always remember inflammatory triad, signs of hypoperfusion. Do not wait for BP to fall and immediately begin with the 1 hour goal. The surviving sepsis bundles are important. Very often it is forgotten. It should be followed in practice. Always remember, if it sounds like an infection, it is infection. If it looks like an infection by examination, it is infection, then probably it is an infection. What is best for mother is also best for the fetus. So always try to be suspicious for sepsis. If it is required, if it is suspicious, we have any suspicious or it is diagnosed, then immediately admit the patient in obstetric HDO ICU and manage accordingly. Thank you very much for your patient hearing. Thank you.
Thank you, Alpesh sir. Who could have talked better than you on this management of septic shock? And we have come to the end of our session 1 today and of ICOG. And moving on ahead, we would be moving on with the session 2, which is on medical legal aspects. And I would like to hand it over to Dr. Mala. Dr. Mala is there? Yeah, Dr. Mala Srivastava, she would be taking forward. She is the head of the department at Gangaram Hospital and ICOG Governing Council member. Over to you, Dr. Mala ma'am. You need to unmute yourself, Mala madam. Kindly unmute Dr. Mala Srivastava.
Yes, ma'am.
Thanks, Dr. Rakhi. It's my pleasure and privilege to conduct the second session of this evening. The second section is on medical legal aspects. And we have a renowned speaker for the first topic of this session. Our speaker is Professor N. Hafizullah Kirubamani. Madam is a former Superintendent Stanley Medical College, Professor Savita University. Madam is past President of Obstetrics and Gynaecology Society of Southern India and President of Chennai Menopause Society. Madam has held many important posts in local society as well as in FOGSI. Has done many awareness programs in Tamil Nadu, and she is a very great teacher, trained in robotic surgeon with field of interest in high-risk pregnancy, menopause, and medical education. Madam is going to speak about overview of liver disorders during pregnancy. Over to you, madam, for your scientific deliberation.
Start. Am I audible?
Yes, madam, you are audible.
But I'm not able to share my screen.
Ma'am, kindly do it. You will be able to do it now.
Yeah. Is it visible?
It's on the way.
It's on the way, madam.
It is
Now
visible.
we can see.
Yes, ma'am. It's visible. You need to slide share mode, put it on the slide share mode. And I think your connection is not that stable. You can off your video if you want to, ma'am.
Okay. 1 minute. Am I audible?
Yes, ma'am. You are very well audible.
Madam, you are audible.
Okay. Yeah. At the outset, I thank the organizer for giving me an opportunity to share my views on overview of liver disorder during pregnancy. Actually, as you know, this is a clinical challenge to diagnose. It is unique that some new and chronic hepatic disease unrelated to pregnancy may result in adverse outcome. Physiological changes in biliary function increases risk of gallstone, which can be a clinical challenge.
Madam, your slides are not moving.
Is it moving?
No.
No, madam, your slides.
Yeah, now it is.
Is it moving now?
Yes, it is moved.
Yes, madam.
Overview of liver disorder. Yeah. But there is a block. I don't know. I am seeing or everybody's seeing. The screen is blocked at a few places. There are black patches.
Empty.
No, some classic signs of chronic liver disease like spider angioma and palmar erythema is also common during normal pregnancy. This is the challenge which will be facing. Again, liver is difficult to palpate and the palpable liver is always abnormal in pregnancy. So coming to the physiology, two important changes are taking place. Facilitation of the cholesterol stone formation because of increase in estrogen. Progesterone reduces bile acid secretion and concentration of this cholesterol increases in bile. The ability to dissolve the cholesterol reduces. There is a stasis because progesterone slows the gallbladder emptying, bile stasis, which promotes stones. The above change leads to the formation of sludge and gallstones in pregnancy. There's a lot of anatomical and physiological changes takes place in the liver.
There's a problem with your slides, madam.
They are not moving correctly. Can you off your video? Then it would be faster at least. There is a lag in between. Your own video, if you could off, then the thing would be better at least.
Now we are able to see.
Yeah.
Yeah, I think it's better, madam.
I think you need to stop share and reshare it again. That would be better because it is coming very slow.
Or ask them to share.
Okay.
I have already given this slides to them. I'll try once more.
Dr. Mala is sharing. Yeah,
I'm sharing, madam.
Okay. You are sharing, no, madam?
Yeah.
Slide number 5, Dr.
I'll
Mala.
go.
Second. Yeah. Yeah. Next, madam. Next. So the liver diseases, previous slides, please, previous slides. So it can be liver disease related to pregnancy. It can be a pre-existing underlying liver disease or liver disease coincidental to pregnancy. So the hyperemesis, intrahepatic cholestasis, acute fatty liver, preeclampsia syndrome come under related to pregnancy. Pre-existing liver disease can be chronic hepatitis, autoimmune disease, Wilson's disease, primary biliary cirrhosis, cirrhosis of other causes, sclerosing cholangitis, and liver disease coincidental can be acute viral hepatitis, gallstone, Budd-Chiari syndrome, drug-induced, and sepsis. Next slide. So among them, the intrahepatic cholestasis in pregnancy comes first and then the HELP and acute liver disease. This is the common things. Next slide. So, and when we look at the time of presentation, the pre-existing underlying disease like cirrhosis, autoimmune hepatitis will present throughout. At any time it can be there. And liver disease related to pregnancy, hyperemesis, as we all know, more common in first trimester, gradually decreases. Intrahepatic cholestasis will occur in second and third. Acute liver disease can be occurring in third trimester. Preeclampsia, HELP syndrome can be second, third, and even after delivery. Liver disease, coincidental acute viral hepatitis can occur at any time. Gallstone, mostly in second, it can occur after third trimester also. Bachari also the first trimester, drug induced at any time, and sepsis also at any time. Next slide. Next slide. Next slide, madam. So she also lost the connection. Next slide, next slide. So this is based on the laboratory findings. Okay, coming to the related pregnancy, the liver diseases, the first one is hyperemesis gravidorum. It occurs in first trimester. We know when the weight loss is more than 5%, dehydration, ketonuria, we can name them as hyperemesis. It can be due to so many hormonal changes, and it depends upon the evaluation, depends upon the vital signs, urine output, uterine size, blood test. Also, we have to find out hematocrit and urine examination for ketone. Hepatic dysfunction, mild elevation in serum transferase levels occurs in hyperemesis due to impairment of mitochondrial fatty acid oxidation has been found in some women. Next slide. Next slide, madam. Next slide. Next slide, next slide. So sometimes we have to differentiate from cholecystitis and other things. And coming to the HELP syndrome, it can develop in the second trimester, third trimester, sometime immediately after delivery. We all know hypertension, proteinuria are present in 80% of the women, but either or both may be absent also. It can lead on to abruptio, DIC, pulmonary edema, and rupture of liver hematoma. And diagnosis is made by the following thing: microangiohemolysis, characterized by cystocytes, cells on bloods, and serum bilirubin will be increased platelet less than 1 lakh. Serum cryptoglobin may be, but it's not specific and it is not included in the criteria. Next slide. Next slide. So the HELP syndrome may be misdiagnosed as acute fatty liver, idiopathic thrombocytopenia, and be appendicitis, cholecystitis, so on. Next slide. Next slide, madam. So according to Mississippi, it is classified into 3, class 1. So the management is, no, it's never been expected management. Irrespective of the gestational age, we have to terminate. The patient has to be delivered. Corticosteroids should be administered for pulmonary maturity if the gestation age is less than 34 weeks. Antihypertensive and magnesium sulfate may be of use, and labor may be induced following cervical ripening with prostaglandin. Intramuscular injection and mostly pudental blocks, spinal epidural may be avoided. Platelet transfusions are indicated if there is a significant bleeding or when the platelet is less than 20,000. Next slide. So coming to the liver hematoma, the clinical features will be acute abdominal pain, shoulder pain, intraperineal hemorrhage. The diagnosis made by the presence of elevated liver enzymes, anemia, evidence of DIVC, intraperitoneal hemorrhage, which can be easily picked up by CT and ultrasonogram. Volume, managed by the volume resuscitation, transfusion of blood and blood products, and immediate laparotomy. The fetus should be delivered immediately. The bleeding from the liver can be controlled by packing and ligation of the hepatic vessels. Sometimes it will end up in partial resection of the necrotic segment of the liver. Next slide, please. So coming to the gallstone, as I already mentioned, it can happen due to the physiological changes. 10% of the women may develop stones by a sludge, and sometime in immediate postpartum also. Only 1% will develop symptoms related to sludge, and increase if age, obesity will be the risk factors for them. Next slide. Next slide, next slide. So the clinical feature will be a typical positive. See, before we could finish, we are going to second. So the liver disease, yes. So the right upper quadrant, positive Murphy sign, tenderness in subcortical region is the typical thing. Patient can have nausea, vomiting, low-grade fever, and mild leukocytosis. Ultrasound gives a very good gold standard for diagnosis. Management is the uncomplicated biliary colic, acute cholestasis, can be treated conservatively. If surgical intervention is required, preferably laparoscope in second trimester. Since first trimester, it leads to abortion, and later on it leads to preterm in third trimester. The next slide, please. Next slide. So this is again a liver disease coincidental to the pregnancy. With the Budd-Chiari syndrome, as we all know, it presents in last trimester or puerperium. Treatment is not different from non-pregnant. Low molecular weight heparin at our dose should be started as soon as the diagnosis is established, and endoscopic therapy for portal hypertension because it is associated with portal hypertension and varices. Next slide. Next slide. And this is again a pre-existing under Madam, am I audible or not? Before I could finish the slides, if people are moving. So the cirrhosis, the worsening jaundice with progressive liver failure, ascites and hepatic coma have been reported in pregnancy. There is increased incidence of stillbirth, premature delivery, hypertension, peripartum infections is associated with ascites. So endoscopic band ligation are successful in pregnant women with varicose vein, which prevents the varicose bleeding in a known cirrhotic who desires pregnancy. Is before she become pregnant, it's better to do a this thing, ligation, endoscopic band ligation. Next slide. Next slide. So again, these are all the things can happen: autoimmune hepatitis and Wilson's disease. And in Wilson's disease, recurrent abortions are more common, but pregnancy is safe and successful when treatment with the chelating drugs is continued uninterrupted. Zinc also should be given. And autoimmune hepatitis, usually it's asymptomatic. Steroids and acetoprenone are safe during pregnancy, but birth defects have been described. They need a careful monitoring during pregnancy for several months, even after postpartum. Next slide. So this can also happen, very rare, portal vein thrombosis. No controlled studies on anticoagulation therapy, but chronic portal vein thrombosis, patients should be offered screening for varices. If present, adequate prophylaxis should be taken. Then only after that, only anticoagulation therapy should be initiated. Next slide. So this condition is primary sclerosing cholangitis of pregnancy. Is very, very rare condition, but it is very progressive. It is coincident in pregnancy. It characterized by progressive inflammation and distraction and fibrosis resulting in liver failure, characterized by itching, fatigue, jaundice, and weight loss. And however, initially progression can be clinically asymptomatic. Next slide. So diagnosis is made by magnetic MRCP, and although not proven effective on the natural history of the disease, Uric acid seems to reduce symptoms and improves laboratory findings. But in end-stage primary sclerosing cholangitis, liver transplantation is the only life-extending option at this time. The course of pregnancy was marked by threatened preterm delivery and exacerbation of the cholestasis. Data on safety to the fetus and the neonate long-term outcomes are very scary. Next slide. So challenges are what make life interesting. Overcome them is what makes them meaningful. Similarly, next slide. So hepatic disease during pregnancy is real challenge because the diagnosis during pregnancy poses overlapping of the features of these disorders. Maternal mortality, morbidity, and fetal survival also is affected, but yet the outcome may be good when we do early recognition, appropriate treatment, and early delivery. The outcome will be good. And thank you for patient listening. Thank you once again, the organizers, and sorry for the difficulty in projecting the slides. Thank you so much.
Thanks, madam. That was a really very comprehensive talk from your side. And I'm sorry for this delay in changing the slides.
So thank you, madam. Thank you.
There was maybe some communication gap from my side. Now it's my pleasure to invite the next speaker of the evening, Dr. Poonam Verma. Madam is going to speak about acute fatty liver of pregnancy. Madam is a very senior gynecologist, and we are here very eager to listen from her scientific deliberation on acute fatty liver of pregnancy.
So a very good evening to all of you. I'll just share my slide in a second. Is it visible?
Yes, madam, it is visible.
And does it change?
You have to make it screen show, madam. Slideshow.
Yeah.
It is not changing? A slideshow, madam. It is not a slideshow, madam.
I am in the slideshow from my side. Can you see it changing?
No, madam.
Okay.
It is not on the slideshow.
Dr. Poonam, you can reshare it again. Probably at times it gets stuck. Stop sharing it and reshare it again and then put it on the slide.
Okay. So I go to share screen.
Yes, ma'am.
Okay. And then I go on to my presentation. Now, is it visible?
Ma'am, make it up. Slide share is there up, ma'am.
See, I can see my
just
slides.
click it on that, no?
Yeah, from beginning. Now,
it has not happened, but you have to double click it, ma'am. Ma'am, you need to click it on the slide.
I am doing that.
Do it again, ma'am. Because it is hidden. Once you do it, then again you have to do it second time. Here you have to do it presentation mode.
From beginning, yes.
Now is it okay?
No, it is not.
No, it is not yet started in slideshow. Yeah, now we can.
Yeah,
done.
Can you see?
Yes,
yes, madam.
Yes. So, my colleagues and dear friends, what I am going to talk to you today is something which is very, very lethal, and all of the gynecologists and obstetricians have faced this. This is acute fatty liver of pregnancy. I bring greeting from Mahatma Gandhi Institute of Medical Sciences, which is situated in Wardha, an interior place in Vidarbha where rural population is mostly there, but we have seen nth number of cases of acute fatty liver. Coming on to the definition, acute fatty liver of pregnancy is a very rare but life-threatening complication of pregnancy, and this generally occurs in the third trimester or a period after delivery. There are a lot of research which has been done on acute fatty liver of pregnancy, but the new thing which has come is that this disorder is a metabolic disorder of fatty acids, where mitochondria in the mother does not have long chain 3-hydroxyacyl coenzyme A dehydrogenase enzyme. There are a number of enzymes which are required for converting long chain fatty acid into the kind of small fatty acids which can be displaced out of the body. But whenever you have LC-HAT deficiency, you will find that these fatty acids, they deposit in the liver. Now, to tell you very frankly, liver has got somewhere around 4 to 5% of fat. But when this kind of deficiency is there in the mother and many a times in fetus, there are a lot of fatty acid accumulation which happens in the liver, and this kind of fat nearly becomes 23 to 30%. This condition was previously thought to be universally fatal, but aggressive treatment by stabilizing the mother with IV fluids, blood products, treating the hypoglycemia has improved the prognosis. The epidemiology, if we go into, we will realize that this is a rare condition. It occurs approximately 1 in 7,000 to 1 in 15,000 pregnancies. Now the maternal mortality, which used to be as high as 80%, has gone down to 18% with simple symptomatic management. And certain complications like DIC, because there are a lot of blood products coming up, which are at right time if given, probably they will prevent the women from going into DIC or infection. After delivery of the baby, most of these mothers, they do well because the stimulus for fatty acid overload is removed. The disease can occur in future pregnancies and the genetic chances are as high as 25 to 30%. Fetus also used to suffer with mortality as high as 75 to 80%, but now it has gone down to 23%, which also is actually high. Coming on to pathophysiology, as I already told you, the long chain hydroxyacyl dehydrogenase deficiency leads to accumulation of long chain fatty acid. When this occurs in fetus, again, there is no oxidation, and then through the maternal circulation, again, these fatty acids come on to the mother. There have been genes which have been isolated, and the most common mutation which have been found is E47-4Q mutation. This is an autosomal recessive inheritance, and the mother is often found to be heterozygous for the affected mutation. Now, if you look into this particular chart, you will realize that ideally from enol coenzyme A, a shortened acyl coenzyme A should be formed, which is actually a very small kind of fatty acid, which is removed from the body. But whenever there is LC-HAT deficiency, you will see that 3-hydroxyacyl coenzyme A forms, and after that, there is no progression of this particular site. So even though there are a lot of enzymes required for fatty acid oxidation, but this is one particular enzyme, 3-hydroxyacyl CoA, which is responsible in mitochondria to break down or oxidize long chain fatty acid into small chain fatty acid. There have been also certain things given that why acute fatty liver of pregnancy happens, because we will see that deficiency happens only in 30 to 40% cases. So some of the hypotheses which have been given is that whenever there is some kind of fetal and maternal mutations, also the metabolic stress of third trimester and environmental stress with high fat diet, these are also responsible along with that to create certain toxic metabolites. And these toxic metabolites, they profoundly cause endothelial cell activation, capillary leakage, hemoconcentration, and then the final complications are acute kidney injury, ascites, pulmonary edema, decreased uteroplacental circulation leading to maternal and fetal acidosis and fetal death. So there have been all hypotheses which are going on, but yet we are trying to find out, apart from that enzyme deficiency, what could all be the other reasons for acute fatty liver of pregnancy. When we go on to pathology, we know that whenever we want to know what happens in acute fatty liver, the liver biopsy is very important, but this liver biopsy cannot be done in such cases where you have DIC. So the cases which have been studied without DIC patients in fatty liver, it has been seen that there is microvesicular steatosis, which is spared some zone of liver, but it is closest to the areas of hepatic artery. Necrosis is very rarely seen, but because of these steatosis, the hepatocyte cells do not work, and what happens is the result of the hepatocyte not working properly. This is the histopathology of the fatty liver and steatosis, which can be seen very clearly. How does this women present to you? So there's a huge, big clinical spectrum of severity by which the women presents, but the most important thing is that over a few days, you will find that the patient deteriorates significantly. The women may come with all the symptoms of liver failure, where she will have persistent nausea, vomiting, which would be the major complaint. There'll be malaise, anorexia, epigastric pain, but there are some systematic symptoms, such as symptoms of pancreatitis, where she will have very sharp pain on the back. She will have hepatic encephalopathy, where she will start having flapping tremors, and one can see how she deteriorates after jaundice. And then, of course, the urine stops coming. She goes into kidney failure, and what she dies of is hepatorenal failure. Also, you will see that these presentations are mainly between 30th to 38 weeks of pregnancy, and headache is also one of the complaints where the liver failure, the products, the toxic products because of liver failure, they start moving on to the cerebral region as well. Many women may have hypertension, which may be with or without proteinuria because of coexistence of hemolysis, elevated liver enzyme, and low platelets, which has the similarity towards the preeclampsia and HELLP syndrome. And in a minute, I'll tell you how you differentiate. There'll be jaundice, ascites, features of encephalopathy, and suddenly you will find that within few days, disseminated intravascular coagulopathy sets in. Now, what is very important is the term hypoglycemia. Now, this is something which differentiates it from all other variety of jaundice, and you'll be surprised that this woman acutely goes into hypoglycemia. And what are the two reasons why hypoglycemia occurs? One is that because liver is not functioning, so there is no gluconeogenesis. And the second is that this decreased uptake of insulin by hepatocytes. And because the hepatocyte cannot take up the insulin, the peripheral blood has more insulin and it utilizes the sugar. And what happens is hypoglycemia. So hypoglycemia is one of the very important symptom or sign when you check the blood sugar. You will find that there is low blood sugars completely going as low as 30 milligram/%. Acute renal injury and multi-organ failure would be there. And then the second important thing what you see here is transient diabetes insipidus. And why does this happen? Because there is increased level of vasopressins, which are produced by human placenta. And whenever this vasopressin breaks down, it forms antidiuretic hormone, which results in decreased ADH level. And this leads to polyuria, polydipsia, and transient diabetes insipidus. So that is something also we have to keep in our mind, because this kind of symptoms are not seen in other variety of jaundice. And then, of course, acute pancreatitis may set. When we look into the signs, we realize that there is progressive jaundice, and this jaundice keeps on increasing because of hemolysis as well. And perhaps half of the affected women also develop hypertension and edema alone or in combination, suggestive of something like preeclampsia. Hypoglycemia, I've already discussed, this is very common. Now, how do you investigate this women? When we do the investigation, as you do the investigation in any case of jaundice, we look for hemogram, where you find leukocytosis, thrombocytopenia, and anemia because hemolysis is going on. Peripheral smear shows hemolytic anemia, thrombocytopenia. There will be hypofibrinogenemia, hypoalbuminemia, and hypocholesterolemia. Whenever we do coagulation profile, we'll see that there's a huge amount of prolongation in clotting time. Serum bilirubin is high, but a very interesting thing here is that it barely goes beyond 10 mg/cent. SGOT, SGPT are increased, but they are not increased as the level of hepatitis. So they are less than 1000 international unit per liter. But what you have to remember is that this is much more than what you see in preeclampsia. These are very interesting guidelines, and there is a, what do you call that? There's a special criteria which has been created for this particular case. And in this criteria, you'll find that there are 14 or 15 points. If you find 6 points increased, then you say that, okay, this is nothing but acute fatty liver of pregnancy. So there are CSAW criteria and several other criteria which have been. Coming on to the treatment of acute fatty liver of pregnancy, please remember that this is a killer. So you have to treat it in the best center where you can have hepatology, high-risk obstetrics, maternal-fetal medicine, or neonatology. However, we do not find institutions where you have all these things put together when you talk in terms of India. So you have to ensure that you give her supportive management in the form of please replace her fluids adequately. Ensure that you keep checking her blood sugar and give her intravenous glucose. Blood products as they are needed, especially fresh frozen plasma and cryoprecipitate, they help a lot. Fetus should be monitored by cardiotocography. Once the mother is stabilized, one should really think in terms of delivery, because delivery is the treatment for acute fatty liver in case you want to save the mother. Ideally, vaginal delivery is preferred, but either if there is any bleeding episode, or we want to deliver the women faster because the women is deteriorating faster, we can go for cesarean section along with the blood and blood products. So this is the management, and emergency cesarean sections have been seen to be the major reasons for acute fatty liver of pregnancy. Pancreatitis is also something which needs acute treatment. However, there's no treatment for acute pancreatitis. Again, the supportive therapy is given, but we definitely do serum amylase and other tests to ensure that we diagnose at least that it is pancreatitis along with acute fatty. People have a question that liver transplantation in these cases will help or not. So, my dear colleagues, liver transplantation in these cases is rarely required. I wouldn't say no, because there are cases in literature which have been mentioned, and they have saved the women also after liver transplantation. But looking into the supportive therapies and blood products and sugar management, we have been able to save the women without doing any sort of liver transplantation. Now, components of pregnancy management includes one, assessing for multi-organ dysfunction and severity of liver dysfunction. We will know all these by these investigations, where what very important are the transaminase enzymes, bilirubin, creatinine, and of course, all blood coagulation profile, ammonia and amylase and lipase. Second is critical care support. As I told you, it should be multidisciplinary approach. We must involve our hepatologist, if not hepatologist, at least our physician, because the aggressive fluid therapy and therapy for the sugar, etc., along with the strict monitoring by pulse oximetry, monitoring urine output and fluid balance, would definitely change the scenario. Monitoring for the treatment of hypoglycemia, I have already mentioned that most of the time we give a continuous infusion of 10% dextrose solutions, which is administered as needed. And we have to ensure that the blood sugar does not go below 65 milligram per cent. Magnesium sulfate has been administered in these cases because most of these women, they present in the later part of the pregnancy, where the women has not completed her term. So in these cases, if women is less than 32, please ensure that we give dose of magnesium sulfate to prevent cerebral palsy and severe motor dysfunction in the offspring. Now, my last few slides, whenever you are thinking of various other disorders or differential diagnosis, preeclampsia, eclampsia is one, and we all know that high blood pressure, proteinuria, headache, seizures, etc., and then bilirubin not going very high, enzymes not going very high, creatinine going a little higher, but not to that extent, will rule out preeclampsia. The second one is HELP. HELP is very peculiar and has a differential diagnosis with this, because the similar symptoms, they are there. But here, she will not have repeated episodes of preeclampsia, and neither will she have those kind of nausea, vomiting, and anorexia, the way you have an acute fatty liver of pregnancy. Hyperemesis gravidarum is very different, comes in the first trimester, so you can rule it out. One more diagnosis by which you have to rule out acute fatty liver of pregnancy is intrahepatic cholestasis of pregnancy. Now, this one will have jaundice, but not to that extent, and one symptom of severe pruritus will probably differentiate it from acute fatty liver of pregnancy. So what are the complications and what are we bothered about? So coagulopathy is one of the major complication, and friends, one single test, bedside test, which is called clot observation time. Whenever you have a woman with jaundice, just take the 5 ml or 10 ml of blood, and you ensure that you keep that blood in a test tube for 7 minutes. And then you see if this is clotting, that means she has not settled coagulopathy. If you break the clot by just moving it so it disperses, then she is about to have. And if the clotting is not there at all, you know that she is in DIC. And then you go ahead with all sorts of coagulation profile. Transient diabetes mellitus, I have already told you. Hepatitis B, pancreatitis, hepatic function, renal failure, I have already told you. My last slide is this. These are the guidelines which have come up, and I request you that you all should see these guidelines. These are guidelines which are there, especially ICOG guideline is there, and there are very interesting, very recent literature, which is by Yusuf Hadi 2022, which tells you how you can manage acute fatty liver of pregnancy. And similar kind of a study in India have also been there, where Reddy et al. Have seen how one should manage maternal and fetal outcome of jaundice, where they have specifically mentioned about the HELP syndrome and acute fatty liver of pregnancy. These are my references. And thank you very much for your patient hearing. Thank you so much, everybody. And thank you, organizers, for giving me this opportunity.
Thank you, madam, for your comprehensive scientific deliberation. Now it's my pleasure to invite the next speaker of the evening, Dr. Vaishali Korde Nayak. Madam is going to speak about intrahepatic cholestasis of pregnancy. Dr. Vaishali is a professor and head MIMER Medical College, Pune, and consultant critical care obstetrics, Ruby Hall Clinic, Pune. Madam is a very renowned teacher and she is very popular with her students. Over to you, madam, for your scientific deliberation.
Thank you so much, madam, for these kind words. And I would like to thank organizers for this opportunity. And I would really like to congratulate the students who are getting this opportunity to attend such classes which are being conducted by ICOG. We had a very good session last 2 days, and today evening they are learning about liver disorders, which is a really complicated topic in case of medical disorders of pregnancy. So students, we've just covered acute fatty liver of pregnancy, and now we will see the next differential diagnosis, and that is intrahepatic cholestasis of pregnancy. I bring you greetings from Pune. Let's see that we have a case, a 23-year-old woman who is second gravida, para 1, but at 35 weeks, she comes with singleton gestation, and she's referred from a dermatologist who says that she is having intractable itching. The itching is primarily on palms and her hands and soles of her feet. It is present at daytime as well as at night, and it keeps her from sleeping. So it is quite disturbing her. Now this patient, if also gives history that in her pregnancy, her first pregnancy, she also had similar kind of complaints. And if she also says that her fetus has died in utero in 3rd trimester, how does this alerts you? And what comes to your mind? What is your first diagnosis? Is our topic, that is obstetric cholestasis or intrahepatic cholestasis of pregnancy. Like GDM, like hypertensive disorders of pregnancy, this is a very pregnancy-specific liver disorder, which has got multifactorial condition. It is characterized with pruritus in absence of any rash or any other skin lesion, along with abnormal LFTs. And if no alternative causes identified with this, then it resolves immediately after delivery. It is of great significance to an obstetrician because the impact on the fetus is in the form of preterm birth, fetal distress, meconium staining, to an extent of having good amount of or good percentage of stillbirth if not delivered in time. Also on the mother in the form of sleep deprivation due to intense pruritus, and sometimes it may lead to PPH if it leads to fat malabsorption leading to vitamin K deficiency. So we have to learn this because it is quite important practice as well as from exam point of view. The incidence is also quite significant. It varies worldwide. In Indian, Asian and Pakistani Asian population, the incidence is around 1.5%. So at least 1 woman per 100 pregnant women. And it is as high as 27% in Chile. This is a physiology of the bile acid formation. Bile acid is the end product of cholesterol metabolism. Gallbladder releases them to emulsify the fat and the fat-soluble vitamins. 95% of these bile acids are reabsorbed in the terminal ileum. They are inherently toxic, So there is a very tight homeostasis, and there are receptors. The farcinoid 10R receptor, which regulates the elevated bile acids by down-regulating the synthesis or uptake of bile acid, or by upregulating the export. If this bile gets accumulated in the liver, the stasis of bile salts in liver sinusoids give rise to the clinical condition, what we are discussing. These maternal bile acids, they cross the placenta. The transplacental gradient is reversed in cholestatic pregnancy. There is accumulation of bile acid in fetus and in amniotic fluid, and that gives risk to the fetus in the form of fetal demise. If the total bile acid levels are more than 100 micromole per liter, the risk is quite significant. It also can lead to meconium-stained amniotic fluid, preterm birth as spontaneous, maybe iatrogenic, or it may cause RDS in the neonate. The etiology is unknown, but there are many factors, like there is genetic susceptibility, adenosine triphosphate binding cassette, subfamily B or member 4 gene plays an important role. The farcinoid 10 factor also plays important role. The reproductive hormones like sulfated progesterone metabolites or estrogen. We cannot forget estrogen here, because estrogen, high estrogen, all conditions where the estrogen is high, they lead to ICP. And also environmental factors like selenium deficiency or vitamin D deficiency can also lead to ICP. So we have to see that the genetic variation as well as estrogen, progesterone. So we all know that they peak in third trimester. Also in multifetal gestation. Also, if the patient is treated with oral progesterone therapy for PTL, that is preterm labor, or maybe the recurrence is there, the patient gives history of recurrence with use of combined OC pills, we have to understand that we are dealing, or this patient is having high predisposition towards ICP. In history, pruritus is quite common in pregnancy, almost in 23%, but only a small proportion would be in case of obstetric cholestasis. This is typically seen in third trimester after 30 weeks most of the times. Earlier, it would be seen in case of multiple gestation. The pruritus can be of mild to intense variety, but often widespread. Typically, the palms and soles, the patient would give classical history that she's worse at night. And there may be other symptoms like dark urine, pale stools, or steatorrhea, where the stools are oily, smelly, always floating. And there can be even icterus or jaundice in less than 10% of the cases. So we need to ask our patient past history of ICP, which is a strong risk factor for recurrence. Multiple pregnancies, twins or triplets, again, a predisposing factor. Advanced maternal age, pregnancy after ovarian hyperstimulation, use of combined OC pills, or maybe history of ICP in her mother or in sister also has a significant correlation. If she has past history of hepatitis C carriage or like gallstones, that also makes her significantly predisposed to this condition. As we have seen the symptoms, there can be associated symptoms like upper quadrant pain, nausea, poor appetite, steatorrhea, or jaundice. The jaundice may come 1 to 4 weeks after the onset of itching, so they may not be simultaneously present. On physical examination, we will never find any skin lesions or any rash in particular, but there would be scratch marks or excoriation seen. That intense the pruritus may be. The prurigo nodules secondary to the scratching can be seen, and icterus can be seen in 14 to 25% of the patient. Jaundice without pruritus is rare. So if we don't have pruritus along with jaundice, then it prompts investigation for other causes of jaundice in pregnancy. and we have to shift our diagnosis in that case. So the differential diagnosis in pruritus, if a pregnant lady is having pruritus, we think of all these things like atopic eruption of pregnancy or polymorphic eruptions of pregnancy or pemphigoid gestinoitis. Or in case, if it is not related with pregnancy, then it can be simple eczema or allergic drug reaction or any other systemic disorder. If along with this, we have abnormal LFTs, then we have to focus on this. And the previous lecture also, you have covered that these differentials we have to keep in mind when the LFTs go deranged. If not related to pregnancy, there can be simultaneous gallstones or hepatic infections or chronic active hepatitis and all other conditions which we have discussed. In case we have the aminotransferases raised, pruritus is present, then we directly hit towards ICP. But if pruritus is absent, then we have to think of HELP syndrome, severe preeclampsia, or acute fatty liver of pregnancy. A word of caution is sometimes ICP can be associated with preeclampsia or acute fatty liver of pregnancy. The investigations here, classically, the bile acid would be raised. So it's a very specific and very sensitive test. So we have to do bile acids. The transaminases would also increase less than 2 folds than the normal pregnancy levels of these transaminases. GGT, bilirubin can also be raised. We may have to do ultrasound. Coagulation screen becomes important if the patient has steatorrhea, because that will lead to vitamin K deficiency and that may alter her prothrombin time and INR. And we also need to screen for gestational diabetes, which is quite routine for all of us. So these are the investigations, how they differentiate. In case of ICP, the symptoms would be mainly in 3rd trimester, pruritus would be the presentation, the SGOT, SGPT would be raised, alkaline phosphatase would be raised, the platelets would remain normal, and the fetal complications would be seen in these forms, which we are going to see in some time. Here we have to see that the alkaline phosphatase and SGOT, SGPT levels, we have to see that the normal adult levels vary than in non-pregnant patient. So we have to always remember the pregnancy values. In cholestasis, it would be higher, the alkaline phosphatase. Bilirubin will also be higher, and these transaminases would be increased 2 to 10 folds than normal. If our patient has persistent pruritus, but the investigations are negative, we still have to keep ICP in mind. We cannot forget it. We have to repeat the LFTs after 2 weeks until 34 weeks, or after that, weekly, we have to keep a watch and treat the pruritus, keeping ICP in mind. Because the ICP is going to affect our perinatal outcome. It can be the preterm delivery or it can be meconium staining, but what's important or what matters us more is the intrauterine fetal demise, which happens, and we need to control ICP to avoid these complications. This adverse outcome is seen when the bile acid levels are more than 40 micromoles per liter. And there are various studies which have said or which have proven that when these values are more than 40, then it sets an alarm and we need to be watchful till we take the patient till delivery, like we are monitoring. And in case the values are more than 100, then it's quite alarming. 1 to 2% increase in risk with every 1 millimole increase per liter. We have to remember when it goes above 40 level. So this cutoff, we all have to keep in mind. And with this, we can bring down our perinatal complications. There are various studies done. The ICOG study, where this was done in UK, where almost 98% of all UK consultants were, the consultant units contributed. And they included all cases with severe ICP where the bile acid levels were more than 40 over a period of 12 months. And they have given us data which says that the almost 669 patients were included in this study, and they have found preterm deliveries in 25%, maybe iatrogenic or spontaneous, and stillbirth was seen in 10 women over 664. So neonatal unit admissions were also 12% in comparison with normal 5.6%. So basically, we need to understand that ICP affects the fetus and the perinatal outcome. Meconium staining of LICA was also seen in cases of ICP much earlier than normal cases, where we see that at 38-39 weeks, we see meconium staining. But in ICP cases, it was seen much earlier gestation than normal. In 16% of the patients, it was seen. So the bile acid and the adverse outcome. So doubling of serum bile acid level increases the outcome or increases the risk regarding preterm delivery, regarding spontaneous or meconium stained amniotic fluid or stillbirth, all of these. So we really need to keep a watch on serum bile acid levels. And these adverse events are basically because spontaneous preterm can be because it is the dose-dependent bile acid level effect on myometrial contractility. So as the bile acid level increases, there is setting of myometrial contractions. Myometrium of women with ICP is more responsive to oxytocin. Meconium staining is due to the increased colonic motility due to elevated bile acids in the fetus. RDS may be due to bile acid causing atelectasis or hyaline membrane disease in the neonate. Causes of stillbirth are unclear, but there is no evidence of chronic uteroplacental insufficiency. So it's not a chronic thing. Instead, there is evidence of acute anoxia in these fetuses causing sudden intrauterine fetal death. Fetal cardiac arrhythmia may be a cause, and bile acid interfere with myocardial contractility is the reason. Bile acid can also cause spasm of umbilical vessels that may cause this acute anoxia and acute insult, leading to intrauterine fetal death. So how to manage this? Basically, when the mother comes with this pruritus, that is her chief complaint, and we need to manage that with the help of loose cotton clothes. Natural fiber is recommended. Then topical emollients like lactocalamine lotion or aqueous cream with menthol. Sometimes if she doesn't get cured with this,
Vaishali, there is no
problem.
Vaishali, there is no sound. I think she's frozen.
There is some problem.
Yeah, everybody cannot. Problem is from her side.
Some internet issue.
Yeah.
I think madam will rejoin. I will give her some time.
Yeah, I think 2 minutes at least she deserves. A minute or two.
I'll ring up or find out.
Yes, madam.
Madam's electricity had gone. So Madam is trying to join through her phone, Wi-Fi. I think we should allow her to complete the lecture. Yes, Madam is back. Dr. Vaishali, you have to unmute yourself. You are still muted. I think technical team has.
Yes, madam. I got unmute. I have unmuted myself. Sorry, we have rains here and my Wi-Fi suddenly got stopped because of electricity failed. Am I audible, madam?
Yes, you are very much audible.
Yeah, okay. So my slides won't be seen. Yes, my slides won't be, I won't be able to this because I have logged in from my phone. I'll just complete it.
Okay, that's fair enough.
Yeah. So we were talking about ursodeoxycholic acid, and we can give it in the dose of, we can start it 300 milligram twice a day, and which we can increase it to almost 1.5 to 200 milligram as per the requirement. Now, what becomes more important in this case is timing of delivery. We have to time the delivery, which is very important because our fetus is at danger of all these complications which we have seen so far. So the guidelines say that in any of this duration, since the diagnosis of ICP, if the bile acid levels are less than 40 micromoles per liter, then we can take this delivery till 37 to 38 weeks. Safely, we can monitor with the routine methods of biophysical profile and NST and take her to 37 to 38 plus 6 weeks, that is around 39 weeks, if the levels are less than 40 micromoles. But if the bile acid levels are in between 40 to 99, we need to deliver this lady in between 36 to 37 weeks completed. Don't stretch her further. In case the bile acid levels are more than 100 micromole per liter, then we have to deliver her at 36 weeks. And in case she develops symptoms like excruciating pain, or there is worsening of liver function tests, or there is prior history of fetal demise in this lady, then we have to deliver her in that range, taking a call from 34 weeks onwards. We need to deliver, and RCOG also support this. And American College guidelines also, ACOG guidelines also support this, that if the levels are more than 100 micromole per liter, we have to deliver her in between 35 to 36 weeks as per the possibility or as per the liver function tests. In conclusion, regular intake of ursodeoxycholic acid tablets improve the antenatal fetal outcome, but induction of delivery in time improves the perinatal outcome. So the take-home message here is never ignore the itch. Itching is a significant symptom. Diagnose it by exclusion. And UDCA is the first line drug. Don't hesitate to start it. It is safe for the neonate. It is safe for the fetus. So start UDCA as you diagnose it, and consider elective delivery depending on the bile salt levels, the bile acid levels, and the outcome would be great. So thank you so much for patient hearing, and I thank the organizers for this opportunity.
Thanks, Dr. Vaishali. That was very comprehensive scientific deliberation on intrahepatic cholestasis of pregnancy. And you have rightly guided us through how to take care of the mother as well as the baby. Now we move on to the next session, that is a panel discussion on medical legal problems in medical disorders in pregnancy. We all know the moderator for this session is Dr. Geetendra Sharma and Dr. Rahul Vani. Dr. Gitendra Sharma is a very popular practicing gynecologist and obstetrician in Ahmedabad for last 28 years. He is also the medical legal counselor, as he has done LLB, and he has been guiding almost all the gynecologists all over India regarding their medical legal problems. He has authored books of law in OB-GYN practice, consents, and laws a doctor must know. He's given more than 1,600 lectures all over India. He is the Vice President of FOGSI, Chairperson Ethics and Medical Legal Committee of FOGSI, and he has been the President of FOGSI and hosted AICOG in 2017. He is also the Joint Secretary of SOGOG. And we are nice to welcome Dr. Rahul Wani, who is the Honorary Consultant, Mathadi Hospital Trust, Obstetrician and Gynecologist, Archana Maternity Center, President of Navi Mumbai Obs and Gynae Society and Associate of Medical Legal Consultant, Medical Legal Consultancies, Member of Ethics and Medical Legal Committee, State Oversight Committee of HIV and AIDS, and Lead Assessor of Manyata FOGSI. And we have a galaxy of panelists today evening, starting from Dr. Alka Puthe, who is the consultant obstetrician gynecologist practicing at Puthe Hospital, Maternity Nursing Home, Amravati. Since 25 years, Madam is a very senior person, very passionate teacher, and she's very popular with her students. Dr. Alka Mukherjee, she is from Pune, a practicing gynecologist. I'm sure she's around here. Dr. Asha Jain, she's also a very senior gynecologist from Raipur, and she's the director of SA Hospital, Medical Director, Cancer Prevention and Relief Society, with 32 years of experience. And she is also very passionate about teaching academics and students. Our next panelist is Dr. Charu Papaya. She is the chairperson of Breast Committee of FOGSI and very active member of FOGSI fraternity. Our next panelist is Dr. Jyoti Banglowala, who is a president of Indore Obs and Gynae Society. Dr. Manish Machave, who is a senior consultant, Machave Hospital, Sahyadri, Ruby Hall Clinic, and he's the honorary Kamla Nehru Hospital, honorary physician to Kamla Nehru Hospital. Next is Dr. Selva Priya, who is a senior consultant, a very senior obstetrician and gynecologist from South. Dr. Varsha Baste, who is a very senior person. She's been the past president of Nasik OB-GYN Society, and she has been the chairperson of the Public Awareness Committee of FOGSI, and we all know her and we are very fond of her.
Thank you. Thank you.
Dr. Mitra Saxena, she is the chairperson of Practical Obstetric Committee of FOGSI, and Madam has been the director of Ashwini Saxena Hospital, Rewari. She is a very passionate obstetrician, practicing clinician, and very passionate about teaching academics and all the academic activity that we do. Over to you, Dr. Rahul, as well as Dr. Gitendra, to carry on the panel discussion. We all are waiting for this exclusive panel discussion on medical legal problems in medical disorders in pregnancy.
Thank you, Mala.
Good evening, everyone.
Hello, Dr.
Dr. Gitendra Sharma has been unable to log in because he's sitting at Delhi airport in the launch.
Oh.
And I'm replacing him as the impact player in the IPL. So I hope I can make that impact. And I welcome all the panelists. I thank
You
all
are
the
equally competent,
organizers
Dr.
for giving me this opportunity. So let us begin with the panel. We saw some messages that please take the post-test panel questions first and then the panel. So everyone is getting late. So we'll have a quick fire panel session here. So can I share my screen?
Yes, please.
Yes, please. Yes, sir.
Yeah. So can you see the slides?
Not yet. Yes, we can see them.
Now you can see them?
Oh, yes.
Okay.
Slideshow. Slideshow.
slideshow.
Yeah, slideshow bhi kiya hai. It will be seen now. Now, am I audible clearly?
Yes, sir.
Yeah. So let me begin on behalf of Dr. Gitendra Sharma and myself. Let us begin with the panel. So we all know medico-legal problems. We are discussing this panel on medico-legal problems in medical disorders of pregnancy. Now, medical litigations are increasing day by day and constantly and steadily increasing. Gynecologists are the prominent people who are sued against or against whom cases are filed. And recently there has been increase in the amount of compensation which has been given against the doctors. We all know the Kunal Shah case where the compensation along with interest and everything went up to 11 crores. Then this Prashant Dhanaka case where the compensation had gone up to 1 crore. So in short, the compensation is going higher and higher day by day. So gynecologists, as I said, are the first or the topmost ranking against whom cases are being filed. The obstetrician's role is a difficult role. We are treating two persons at a time, the mother and the fetus. And the changes in pregnancy could be physiological or it could be a pathological also. So the new talk is of procedures and he who pays the piper calls the tune. So ignorance of law is not an excuse. So in 40% of the litigations, doctor is behind a doctor. So mind you, should be very careful giving any loose comments against your colleagues. So let us begin our talk or our questions. So my first question to the panelists are: what are the different fora in which a complaint can be filed against a medical professional?
Can I answer, Dr. Rahul? Dr. Alka
Yes,
Kuthe. Actually, what happens when a complaint has to be filed in the court of law, there are different parallel options for the patient or the consumer. Like they can file the case in our medical council, they can file the case in consumer forum, district consumer redressal forum, they can file the case in criminal court, civil court, human rights commission, even medical council also they can file. So at the same time, there are different 5-6 options by which they can register their anger or redressal. They are aggrieved, they want justice from all these different fora. So all these 6 rather council, then MMC, state council, respective state council, along with civil and criminal court, they can file simultaneous complaint apart from human rights commission.
Anyone wants to add anything more to this?
Just want to say that first patient should launch a complaint in the state medical council first, and then if needed, then only through the civil or criminal court.
Madam, who has the choice? Whether the patient has the choice to file a case or if it's where the case will be filed.
Where to launch the complaint is from the side of the patient only, from the side of not from the side of doctor.
It's a patient's discretion where to file the complaint. It's a patient's decision. He is the person who can file the complaint or any person on his or her behalf, consumer's behalf, but it is their choice where to file the complaint. They can file simultaneously to different fora, different courts.
Varsha madam, can you tell us briefly what are these different fora? How do they differ? Varsha madam. I think Varsha madam has got locked out. So let us, Charu madam, if you can throw some light on this. How do these different fora differ, or what is the different kind of punishment this fora can give?
Yeah, so obviously we realize that, if a case is filed in the criminal court, it will be one of the highest kinds of, penalties which the doctor will have to face. And so the smaller the courts, probably it would be a better way of settling things in these earlier courts. I would not want it to be filed in a criminal court. That is for sure.
Dr. Rahul, may I intervene?
Yes,
sorry, Dr. Asha Jain.
This my internet was not. What is it you asked? So I'm sorry.
No,
Yeah.
Dr. Rahul.
Dr. Rahul,
may I speak?
Yes, ma'am. Please go ahead.
I'm Dr. Asha Jain.
Yeah.
So actually, there are any monetary reward. It gives you different kinds of punishments. So, and not every case is eligible to be filed in a criminal court. Then you have the medical counsel where you can just complain against somebody's professional work and all. And then the third is the consumer court, which can be a district court, a state court, or a national forum. Now, after the amendment, the national forum, the city forum, district forum.
I think, madam, your connection is a little poor, so we cannot hear you properly.
Award up to 1 goes up to 10, and you can't hear me?
No.
No, ma'am. Your connection is getting disturbed quite a lot, so we can't hear you properly. So, in short,
I'm traveling. So, what did you ask? I'm sorry, I'm traveling, so it is becoming disconnected on and off. I will try.
Yeah.
Dr.
So
Rahul,
let me cut short this and let me
Dr.
finish
Rahul,
this.
basic difference will be when the patient wants monetary compensation or damages, they will go into civil court. When they want, doctor should be penalized, rather imprisonment. They want that a higher action should be taken because of their whatever damage has occurred to the patient. So monetary, civil forum, consumer forum, and with this criminal complaint, it will be punishment, imprisonment, and or fine. It can be there, both or all.
Yeah, and the medical council can take only disciplinary action like removing your name from the register for a short time, suspension or cancellation of your registration. So that is the basic difference between all this fora. Now, who can file a case? Whether the patient can file, or the relatives can file, or social organization can file, or can a municipality file, or government can file, or anybody can file.
Any aggrieved patient or his her relative, or any organization who is non-profit organization, they can file a complaint, or the relative means the beneficiary of the patient also, they can also file a complaint.
Secondly, in case of criminal complaint, there will be state against that particular doctor. So there will be state party in case of criminal complaint. So state versus that doctor will be there. In case of consumer, direct consumer can go against that doctor, but state will not be involved. It will be involved in criminal complaint.
Yeah. So now in different acts, there are different authorities.
The legal hires of the patient or the relatives means the representative of the patient, they can also launch a complaint.
Yeah. So now in different circumstances, different authorities can file a case. Like if it is a criminal case, like in PCPNDT or state PCPNDT or MTP, the state authorities or the authorities under those acts can file a criminal complaint in the court. So it is the municipality or the government which are the authorities in this act. Now in criminal cases, usually if the patient is living, the patient will file, the person who is aggrieved has to file, or if the patient is not alive, the patient's relative can file. Consumer courts, any of these people can file. Yeah.
And if the patient is minor, then the parents or the legal guardian of the patient, they can hire sue the complaint.
Yeah. So let us move ahead. Should we preserve OPD documents? And or how long?
We must preserve OPD documents because it is important. Document. That is only that will only save us from all laws and litigations. So every OPD paper should be preserved.
So, madam, what do you do in your practice? Charu, madam, do you preserve all OPD documents?
This is a good question. Very often it happens that, you have two kinds of records which are maintained. One are the handwritten ones, and you have some which are the digital ones. So when you have handwritten ones, the pile keeps on increasing, and it becomes very difficult to store OPD documents, especially in busy OPDs. So as far as I'm concerned, I have a digital software. So because of which I'm able to preserve all my OPD as well as IPD documents. And there are varied, number of years. I mean, you can correct me if I'm wrong, but OPD documents, they claim should be kept for 2 years. And if there's a problem, then it has to be kept lifelong. You can correct me if I'm wrong, Dr. Vani.
Yeah, now there are no specific.
Dr. Vani, what I think, because the funds are available, we can complete the document. We can preserve the documents in our computer very well. So it is not, once the patient comes, we can fill in the computer all the data. So it becomes like permanent.
Yeah, we're talking about
for how long?
The handwritten documents, how long to preserve? That could be a question.
Now, this is a practical problem. How to preserve OPD document? Now, if you say handwritten documents, as Madam said rightly, it piles on and it in a difficult.
We have to have
busy
OPD
computer. Yeah, in a busy OPD, it is difficult to preserve so many documents. And if you preserve it digitally, there is a problem of how do you produce it as an evidence in the court, because digital documents require additional steps to be provided as evidence in the court. So there is no specific guideline on how long an OPD document has to be preserved, but it is a good practice if you can make some provision to have some record, whether it is electronic or anything. Because when a patient wants to file a complaint, he will take away the documents which are not in his favor and file only those documents which are in his favor. And if you don't have any record, it is difficult to know what you have done for this patient or what you have advised for this patient. So if it is possible, preserve it as a digital document that will not occupy space, and you will have some reference to put forward in the court.
Yes, as Charu suggested about the 2 years of the preservation of OPD documents, there are some specific procedure we are doing in the OPD, like removal of the copy or insertion of the copy. Then sometimes that particular patient's document that particular document should be preserved like the IPD document only. Sometimes we are doing the OPD specific procedure. So as there is no rule of preserving the OPD document, but we have to preserve that documents like the IPD file only.
Yeah, so that will save you from, because even OPD cases can file complaints, and that will be difficult to handle if you don't have any of the documents, and all the documents are in the hands of the patient.
Yes.
Now, patient is suffering from, I can't see this. Yeah. Patient is suffering from severe hypertension in pregnancy and is not following your advice. How will you handle such situation? Alka, madam?
Her connection is lost actually.
Okay, Jyoti madam, can you take up this question?
Yes. If patient is not following our, like first, if patient is not coming continuously to our OPD in the giving time, like in every 15 days or every 1 month, we have to clearly mention on our OPD slip. We have to make our slip in context of the her mother-in-law or her husband. If they are saying he or she is not taking the medicine, we have to write the patient is not taking medicine. Patient is not doing follow-up in proper time. We have to write these things, though only our sign will be suffice, but we have to write these things, and we have to every time counsel the patient and write in the detail on the OPD paper only that we have counseled about all the what can occur if they are not following advice. So we have to write everything, every side effects. Even if we are giving certain medicine about the hypertension and patient is not giving, we have to write this. If patient is taking the medicine, irregular taking of the medicine, we have to write this. Counseling and writing and documentation. This is the only thing we have to do. But if sometimes we write on the OPD paper, the patient is not taking medicine, then patient's husband all of a sudden they say, "Madam, aapne ye kya likh diya hai? Aisa to mat likhiye." But we have to write this particular document and take a photocopy or take a, even if you are not having a good app like Charu said, app nahi hai to bhi aap photocopy kariye, carbon copy kariye, and then one copy for your record also that particular patient is not following your advices.
Jyoti madam has said you have to document on your papers the patient is not following advice. Can you refuse to treat this patient? Charu madam,
I don't think the first thing is, I think it is necessary that rather than alleging her that, she is not taking her these things, I think would be a good question to greet her, make her a little comfortable, and try to find out the reason why she is not taking the medication, rather than just putting some, just blaming her completely. If at the end of this interaction, which should be a polite interaction, if we realize that she is not being, compliant, I think that we can just make a comment that it will be difficult for me to look after you in a good way, and you just might need to change your doctor if this continues. This is how I would probably talk to my patient.
Very rightly said by Charu madam. If the patient is not compliant to your advice, you can refuse such a patient. But see that whatever is the crisis or whatever is the severity, you have to manage her, get that into control, and only then transfer. Now, if it is an emergency, first stabilize her, and then you can politely refuse or refer this patient to someone else if they are not following your advice.
Sir, but Rahul sir, sometimes the patient, when we refuse to treat that patient, after 2 or 3 months, even in the eclampsia or the pre-eclampsia state, that particular patient comes to telling the hospital staff our old OPD paper that we are madam's patient, and they are getting admitted or they are insisting upon us. Then that time, can we refuse this patient, sir, on admission?
See, in an emergency, if the patient is come in an emergency, in a crisis, you need to stabilize the patient.
Okay.
Only when the patient is stabilized, you can refer. You cannot refer a patient in a crisis situation or in a situation where she is unstable. Only when she is stabilized. Now, patient having full-term pregnancy with severe PIH. Now, patient has been advised LSCS. Patient is not giving consent, not even ready to sign refusal. How will you handle this situation? Varsha madam, can you, if your connection is stable, you can.
Yeah, I will try if it is stable. See, first thing is every patient you have to have good rapport, good counseling, good time, and have good.
I think again there's a problem.
Can you hear me? Can you hear me?
No, we can't hear you, madam. Is Alka madam around? I think Alka madam has also lost the connection. So I think only Charu madam is left to answer this question.
Don't worry.
Can you hear me?
Sorry.
So now this patient is severe PIH. You have advised LSCS. Patient is not giving consent. She's also refusing to sign a refusal consent. How will you handle the situation? Now, what you can do is any other patient who is in your wards or any relatives who are there, or other patients' relatives who are there, you can counsel the patient in front of them and take their signature as witnesses. That the patient has been advised Caesar, but the patient is refusing, and this has been counseled in front of them. And as witness, you can take their signatures, and you can advise them if they have faith in some other doctor, they can be transferred or they can be sent to the other doctor. So what is the role of antenatal counseling and what should be the content of the counseling?
Yeah, so antenatal counseling is a very, very important part, and we as busy obstetricians find it really difficult to spare that much time, but probably we all need to realize that medico-legally, if we wish to be safe, we really need to give that kind of time to our patients. There is something called as gather. That means greet, ask what is the reason for her visit to you, discuss what is her situation, that is, tell her everything. What is her current situation? How is the pregnancy going to proceed? What are the various kinds of medications she'll have to take? What are the investigations she'll have to undergo? What could be the possible risk factors as far as she is concerned? Help her in decision making. That is the edge part of it, because, in the West, probably they very often say that, yes, these are the choices and you have to decide. But very often the patient would want an expert advice, like that is why she's here.
Can you hear me?
Can I complete? Yeah. Help her to make a conscious decision about, the hospital where she wishes to deliver, the route of her delivery, and so many other things. Explain what are the various problems that can occur to her and when she has to return back. Now, all this counseling can be done by a counselor if you have one in your hospital, but most of the times it is you yourself who has to look into all this. And so I think that it is very, very important today that we realize that with advancing maternal age, so many other problems and complications occurring. We have most of our patients are high-risk patients. And so we have to counsel her very correctly and rightly, giving her adequate amount of time. It has been seen that, barely that the doctors who got sued against the doctors who didn't get sued for any particular thing, the doctor who didn't get sued spent only 1 extra minute with their patients. And this, spending some amount of time with your patients is probably very necessary.
Very well said, madam. Especially with our pregnant patients, because the pregnancy is just a physiological condition, but the things can turn very rapidly and suddenly the patient can deteriorate, and there could be complications. Complications like PPH and all those things can happen suddenly, and in a matter of minutes or hours, the patient can be lost. So all these risks, if they are told antenatally and the patient and their close relatives counseled, then it will go a long way while managing this patient. Jyoti madam, would you like to add something in this?
Actually, I lost the connection. That's why I joined with the mobile again. Okay. Actually, antenatal counseling is good, and if there are some classes or if you can help them with the counseling session, and if you tell them about the other patients, means there are the peer group facilities if available in a hospital, that will be good for that particular type of patients.
Now let's move on to this. My husband and wife both are suffering from thalassemia minor. And what should you do for such a patient? Or my question is, both of them are thalassemia minors and it has been missed, and post-delivery, the baby is found to be thalassemia major. Now, how would you handle this case? Is this negligence?
No, first of all, if the thalassemia minor patients, if the husband and wife both comes to you, then you have to tell them about the percentage of the thalassemia major. You have to tell them clearly 25 to 30% of the chances of giving birth of the thalassemia major child. And if then they are agree for this thing, then the means all the tests and diagnostic tests and investigation, that all should be done written with the one line in your OPD in IPD paper. There are chances of giving birth of the thalassemia major, and the proper counseling and documentation should be done in the OPD paper. But if they are not your patient and they directly come to you after 7th month of pregnancy or 8th month of pregnancy, and then they give birth to the thalassemia major child, then you have to see what type of counseling has been done previously, or either you or your colleague is at fault. What sort of medical support you can give to them. Basically, nowadays, not a single gynecologist is doing such type of negligency. The negligency is the patient side, but in particular, this thalassemia patient. But if the thalassemea major child is born,
question to you. So all your antenatal patients, you do a thalassemia.
Excuse me,
yeah,
Dr.
Yes,
Gitendra wants to join. Tech team, please allow him to join. Sir has given a message that he wants to join, but it shows you're not allowed to register. So please, tech team, please allow Dr. Gitendra to join.
So meanwhile, as he's joining, let me continue till he joins. So my question to say Charulata madam is, do you do routine antenatal screening for thalassemia in all your patients?
Good question. Actually, in metros, very often we test all our patients for the thal trait. Many of them come with a report of a beta thal trait, and most of the times when we see a hemoglobin report of less than 9.5, which is not getting corrected by your hematinics, then that is the time that we suspect that this could be a thal patient. But sometimes it can be too late for this thing. So it is definitely, at least in metros, we are definitely doing checking for the beta thal trait.
So is it?
No, we are not doing a thal trait. There is a type of patient. Then we do, as I'm working in the charity hospital, if particular belt comes to us, then we do the thal trait. Then we
Madam, your connection is not stable. We can't hear you properly. So, madam, any guidelines which say that mandatorily thalassemia screening should be done in all the antenatal patients?
No, there are no such guidelines which mention this, but areas which are pandemic for beta thal, like there are some areas where you may find that is more for sickle, I think, not for beta thal. But I would suggest that if you see a low hemoglobin level which is not responding to iron, we have to make sure that we do the beta thal test. That is for sure.
The
And
take-home
if
message is,
a patient comes for prenatal counseling and she tells that she's a beta thal trait, we have to make sure that that the husband's beta thal is done. But I had a couple who were, where both of them were beta thal trait positive, but they, they wanted to go ahead with pregnancy. They refused any kind of PGD, and thankfully the baby turned out to be a thal minor. But you do get such couples who, would want to go ahead in spite of both being thal minors.
so the take-home message is, during your antenatal period, be vigilant. If you are not doing thalassemia screening for all your patients, look at the hemoglobin levels and look at the Medzer index. And if you suspect, please do it, because if it is missed, then the case could be filed against you if the baby turns out to be a major. Now, what is high-risk consent? What is high-risk consent? When it should be taken? Is it advisable in all medical disorder patients to take an high-risk consent? Jitendra sir, are you there?
Recording in progress. Can I open?
Yes, ma'am.
Actually, what happens, high-risk patient, if we can say each and every patient is high-risk patient nowadays, and each and every patient can be a potent litigant. So, but if there's certain high risk associated with pregnancy, like medical disorders, health, eclampsia, diabetes, thyroid disorder, any medical condition with pregnancy, we should always have antenatal classes. In antenatal classes, we can explain. And when the patient is admitted for management or OPD procedure also, then that time also we should tell what are the high risk factors in that patient. And when a patient gets admitted for delivery or cesarean section, first consent should be high risk consent, so that patient and relatives come to know what is the pathology associated with pregnancy. And if in case certain mishap occurs, they are ready to accept the mishap. What happens every time, what we say, everything is well, all is well, all is, sab kuch theek hai, sagar theek hai. So sagar theek hai, all is well, this statement is remembered by the patient's relative. And when certain mishap occurs, they don't excuse doctors. They say, आपने तो बताया सब कुछ अच्छा था, फिर ऐसे कैसे patient dead body बाहर आ गई, अच्छी खासी patient अंदर गई और dead body बाहर आई, because they are not ready with PPH. PPH can occur with the patient, pre-eclampsia patient. Anything can happen during section also, eclampsia patient. So all these things should be explained in high risk consent, so that at least their mind is ready that certain problem can come during management of the patient.
Jyoti madam, would you like to add something here? Madam, you have to unmute yourself.
Yes, actually the host was not allowing me to unmute myself. Okay. Actually, we are not taking high risk consent in all the patients, sir. Just seeing the past history, the family history, and if there is any medical disorder, seeing the eminent medical disorder, then only we take the high risk consent. In all patients, we are not taking high risk consent. But if giving the blood, means the blood component, if the patient is even anemia, if anemia of about 9.5 only, then also we are taking. If there is a single element, then we have to take a high risk consent in today's scenario.
So any high risk in your antenatal period, the patient needs to be counseled and they need to be informed. So,
yes.
And this needs to be documented in your papers.
Yes.
And wherever you feel this patient is getting a little more complicated or this risk, you better take a high risk consent.
Not even before taking the becoming the complicated one. Even if it is not complicated, but we are foreseeing the patient's condition. If it is even moderate anemia, moderate PIH, then also we are taking the high risk consent nowadays.
Dr. Rahul, somebody asked in the gallery another question, whether we should take high risk consent for each and every patient that she will have PPH. I already told, when there's some certain factor like anemia, history of previous APH and PPH, history of placenta previa, associated medical condition in this pregnancy, we have to take high risk consent, because PPH sometimes in unpredicted, but at times even normal patient also can have. So in that case, antenatal classes will help. That will help, though the patient was normal, everything was normal, but certain things are unanticipated, unexpected. But in high-risk patient, we have to foresee everything and take high-risk consent. Every patient, we can't take consent for PPH, because it is like hemoglobin in 11 gram %. Everything is okay in this ANC checkup, everything is okay. But If there is some associated medical disorder, that we have to take high risk consent. And in case of other antenatal cases, if you have good antenatal session for them, at least they will see what can happen after normal labor, after cesarean section. So sparingly, we should do all these things for high risk especially.
So high-risk patient should be reserved only for patients where there is a severity and you anticipate that some complications can happen. If you take it for all and each and every patient, there is no meaning of this high-risk consent.
And I think that sometimes you might unnecessarily end up scaring the patient too much, which is not what we are here for.
Actually, in the normal delivery patient, if we are not foreseeing anything or not anticipating, then there is just a blanket type of consent is enough to say there may be risk of this. But actually, sometimes patient to bhag hi jate hain. If you are saying in the normal patient, you are saying you can land up in the PPH, wo patient to kabhi nahi aayega aapke paas. Then you have to foresee, you have to anticipate seeing the past history, family history, and then only take a high-risk consent.
Absolutely.
Now, this is a patient, she was admitted at 10 a.m. in the morning, around 36 weeks of pregnancy. She complained of severe vomiting. She had severe bouts of vomiting. Admitted, symptomatic treatment was given, and suddenly this patient collapsed at 4 p.m. Now, what will you issue a death certificate for this patient, or what will you do in such a case?
Dr. Rahul, this is sudden episode. Severe bout of vomiting, and the patient was rather unconscious, might have aspirated, or there are certain elements of vomiting, behind vomiting. That will be at the background if there's a proper history taken. But in this case, we have to go for postmortem because we don't know exactly what is the cause of the death. Because patient got admitted at 10 a.m., died at 4 p.m. after single bout of severe vomiting. It was severe vomiting, of course, but it was not postpartum. It was not full term also. So again, the question is about issuing of death certificate. When we don't know the cause of the death, how can we issue the death certificate? If you know the cause of death, we can certainly give. But in this case, as there was severe vomiting and the patient died at 4 p.m. So better we ask the police. We should write a letter to police officer. A certain death has occurred in my hospital, and they will come. They will do the postmortem. But doing postmortem is their job. We have to just inform the police officer and ask for the request for the postmortem. But if the patient's relatives say no, that is jamila between that postmortem, that police officer and the relatives. But we must always inform police, because this type of patient death can create problem in the future for doctors. And even that maternal miss cases, that maternal death review, it can be asked to you, what was the cause of maternal death? So when we don't know the cause of the death, better go for police office, regional police station, send a letter. They will come, they will take charge of the body for postmortem.
Sir, actually,
and we should never issue death certificate unless and until we know the exact cause of death.
Okay. Yes, sir. I just want to add one thing. If the patient is our antenatal patient, so we should know we must be knowing about all the medical history, and then we can correlate about the vomiting thing. But there is one case happened, such case just 5 months back. We should give full empathy to the patient. If the patient died suddenly, we have to counsel the patient, and if they allow us, if your center is well equipped, we should give them an option of postmortem LSCS also. It is not actually, we are living in the era of when 36 weeks pregnancy is actually good, fully grown baby inside. So we should give the ask them about the postmortem LSCS. If the patient's relatives are friendly, or you can say they are allowing you with giving proper consent, you have to do the postmortem LSCS and then only this postmortem thing should be done.
Madam, are you talking about perimortem LSCS, where you have identified the baby heartbeat is still?
Yes. If the heart rate of the baby is there, then we have to give a chance to the patient's attendant. They have to be an option.
So perimortem LSCS is a big issue in itself. It's a separate.
No, sir, but in the institutions, we have done 2-3 perimortem LSCS actually, and that is the best thing. Actually, all the attendants, they are so. Actually, they think doctor is thinking about us. Doctor is thinking about our baby.
So perimortem
just to
analysis
save
is
our
basically
skin and
to save the
nothing
baby when
behind.
the heart rate is there, and it has to be done very quickly within 3 to 5 minutes of the patient's collapse. Otherwise, we will bring out a baby which is severely asphyxiated.
You have to just ask the attendants. You have to just ask the husband. At least in the court of law, they can't say they have not given this option.
In fact, in such cases, you don't need consent also. You don't need to shift the patient also. Just take the incision, deliver the baby, because there is no circulation and there will be no bleeding or anything. So once you have taken the baby out, then you can compress and then shift the patient.
And there is a study in the one patient, the patient was collapsed, and when they are doing the perimortem, the patient suddenly have the full blood pressure.
Yeah. When you do, this is part of a resuscitative step. In cases when the patient collapses immediately, so bringing out the baby also helps in resuscitation.
Yes.
No, patient of severe PIH developed acute renal failure. You are a gynecologist, done your PG from Kidney Institute. Will you call nephrologist or will do the treatment on your own?
I will call the nephrologist.
The point is, but she is the case of severe PIH and she has suddenly developed acute renal failure. You as a treating doctor are by her side. For the nephrologist to receive his or her call and reach your hospital, I think the basic primary treatment can be started by you with your knowledge or with a maybe telephonic consultation from your nephrologist. So till your nephrologist reaches there, I would want to stabilize my patient to the best of my ability.
Yeah, so acute renal failure in case of severe PIH is a known obstetric complication. So you are well within your rights to start the treatment, and whenever you feel an opinion is required, you can take an opinion from a nephrologist.
Yes. Be safe on our papers. I have to send a call to the nephrologist. Meanwhile, I will stabilize the patient, but I will send a call to nephrologist also.
Now, will you refer all patients suffering from gestational diabetes or hypothyroidism to the endocrinologist?
No.
Again, we have
today is the era of consumerism. I always say, even if we know a treatment for gestational diabetes, even if I know just a treatment for hypothyroidism, it's my duty to either at least have one consultation with diabetologist and endocrine rather specialist. Then she can continue the treatment and I will monitor the patient. But gone are the era when we used to give everything to diabetic patient and hypothyroid patient. Because if something happens in the management, during management, it will be asked to you why you are not refer the patient to endocrinologist because she is pregnant along with endocrine disorder. But I can treat a patient that I know, but better to have the opinion of gestational diabetologist and endocrine specialist.
So I think.
Yeah, madam.
I have learned the management of GDM. I've learned the management of hypothyroidism, and then otherwise, why are these included in my curriculum anyway? So I would give the choice to my patient. I would tell her, look, lady, you are having mild hypothyroidism, and I think that I'm capable of looking after this problem of yours. If it is okay for you, I would like to prescribe you the medicines. But if you feel that you wish to visit a specialist, then yes, I shall definitely refer you to one.
Actually, the court of law says the standard of care is seen by the whatever the nearest medical college was doing, what is the nearest practicing area was doing. So being a MD-DGO or being the gynecologist, in our curriculum, that particular thing is there. And our all the medical college and our teaching institutes are doing the such thing. So we are not liable to show every patient to the diabetologist or the endocrinologist.
Yeah, very well said. So you have to individualize. There's no straight jacket rule that all patients need to be referred. You can take your individual call wherever you feel you need help.
Actually, the treatment must be approved in our index general. The treatment must be approved in our curriculum that we have read this thing, and then we can treat the patient, sir.
Now we'll go fast. Last 2 or 3 questions. Patient suffering from heart disease diagnosed antenatally. Will you do delivery in your own setup, small private nursing home, or will you refer a patient to a setup with ICU backup?
I will refer.
Or I will the patient, HDU. Refer to the HDU.
Okay. Patient having 32 weeks pregnancy with gestational diabetes needs delivery. Will you give steroid for lung maturity? Doctor gives steroid and baby delivered an IUD.
No, I will admit the patient and give her the steroids for lung maturity, explaining to her that the steroids will cause an increase in her blood sugar level and I'll need to monitor it, but they are going to be extremely useful for her baby. And I don't think that is the steroid which will cause the IUD. There must have been some other complicating factor. And I'm sure all our medical textbooks will vouch for that.
Yes, so all your medical references will support you even if there is a sudden IUD, but steroids are definitely not that cause. And definitely steroids will increase the sugars, but you have to monitor and control them. So you need to give the steroids if you're delivering antenatal. Thank you very much. I thank all the panelists for their lovely interaction and good take-home messages. Thank you, everyone.
Thank you, Rahul sir. Thank you very much. I am very sorry about the internet instability.
Yes, Dr. Jitendra, but Dr. Rahul, you were fantastic. Thank you so much.
I must congratulate Dr. Rahul and the star panelists who have discussed, taken all the cases very nicely and discussed this panel very beautifully. Now we can go ahead with the post-test session. Nilima, we have to have 10 minutes of post-test session.
I will stop sharing my screen. Yeah.
Have you started the post-test session? Because students are waiting for it.
Nilima, please share link in the chat box.
Yeah.
Yeah, it is there now. It is there.
Yeah, the time, I think time starts now.
Yes.
For the students to take the post-test. Yes. Maybe two. I think, Nilima, we should give them the answers also today itself, because otherwise the students will not get any chance to know the post-test answers for day 3 before I propose the vote of thanks. I think answers should be given.
Mala, I think we'll put all the answers of all 3 days along with the recording on the website.
Okay, okay,
Right?
that's
It's
fair
already
enough.
past 8 o'clock.
Okay,
People
that's
have
fair
been
enough.
waiting
That's fair
here
enough.
for the last
So
4 hours.
it's my privilege and pleasure to propose the vote of thanks for this extensive, exhaustive academic bonanza that we witnessed for last 3 days. I must thank our FOGSI president, Dr. Rishikesh Pai, for allowing this program under the ICOG banner. I thank our madam, Dr. Lakshmi Shrikhande, who is the chairperson of ICOG, under whose leadership this program was conceptualized and done. I thank Dr. Parag Beniwala, our vice chairperson of ICOG, who is a very comprehensive person for all the academic activities which are done under the banner of ICOG. It's my privilege to thank Dr. Madhuri Patel, madam, who is the Secretary General of FOGSI. Madam is a very simple, humble person, always helping each and every one from the FOGSI. I thank Dr. Ashok Kumar, who is the Secretary ICOG. Sir is a great academician with always having bright ideas. I thank our Vice President, Dr. Charmeda, who is the series convener, and she's also the ICOG Governing Council member, for initiating each day the program. And of course, the great thanks goes and great appreciation goes to Dr. Sneha Bhuyar, madam, who is the convener of this 3 days program. She is also the ICOG, the Governing Council member, and she has been the chairperson of Breast Committee of FOGSI. She has planned, crafted, and worked really very hard to make this program design and conceptualize and to see that this program becomes a great success. I thank Dr. Pratik Tambe, who is a co-convener of this program, and he's also the ICOG Governing Council member. I thank all the coordinators, Dr. Supriya Jaiswal, who is the chairperson of the Adolescent Committee of FOGSI, Dr. Priyankur Roy, who is the chairperson of Public Awareness Committee of FOGSI, Dr. Rakhi Singh, who is the chairperson of the Endocrinology Committee of FOGSI. All the 3 days saw very experienced, esteemed star speakers who handled each and every topic very nicely and very intelligently, giving very crisp take-home message to all the delegates as well as the student. I thank all the moderators of the panel discussion. We had nice, great brainstorming panel discussion all the 3 days. And I thank all the panelists who took active participation in discussing the modern day-to-day case in great details. And they have given crisp take-home messages to all our delegates as well as our students. All the topics which were covered nicely was hypertensive disorders of pregnancy, gestational diabetes, anemia, heart disease, thyroid disorders, and of course, infections, liver disorders, and medical legal aspects in last 3 days. Special thank goes to Dr. Nilesh Balkawade, Dr. Deepti Gupta, and Dr. Rajesh Ravi, who has helped in making the quiz of all the 3 days, especially for the 3rd days. I thank all the students and delegates who have logged in patiently for all 3 days, and I'm sure they have taken great take-home messages and they have really enriched from the 3-day scientific program. I thank the ICOG technical team, and definitely they have been helping us throughout the program. Thanks everyone. Good night and goodbye to each and everyone.
Yeah, thank you, Mala. I'm here to appreciate the efforts of my Governing Council members, Dr. Sneha Bhuyar, who was the key person behind this. Mala, the excellent conduct of today's program, and you were sitting here all through without getting bored. So that is also important after working throughout the day. Sitting in one place and managing the program is something really good, and hats off to you. Also, I want to appreciate efforts by Rakhi. I can't see her today, but even the 2 coordinators, Supriya is here. Supriya, thank you for chipping in even yesterday when Priyankur was held up, and of course for the first day. And thank you to Pratik and of course series convener Chamila. Just for the delegates, please visit ICOG website www.icogonline.org. all the recordings of all 3 days program will be available just at a click on the ICOG website in the near future. Similarly, we will be sharing the test questions and answers for your information. Right. So thank you very much on behalf of ICOG for being here and motivating us to do better and better. Thank you. And good night.
Thank you, sir. Thank you, Maladi.
Good night. Good night, everyone. Thank you very much.
Good night and goodbye.
Thank you. Thank you, Mala, Madam, Parag, Sir, Supriya. Thank you.
Bye, bye, Jyoti.
Bye, bye, Dr. Jyoti.
Bye.
Nice to
Thank
see
you. Thank you very much for giving us opportunity. That was all 3 days very good. Thank you, man.
Okay,
Thank
bye.
Thank you. Bye. Good night,
Wonderful
Mala,